Should I start now?
Yes, ma'am.
Namaskar. Good evening to all, and I welcome you all to this certificate course Urogynaecology surgery. And for today's session, I would like the chairperson for Dr. Kavita Baranwal, madam, for further proceedings.
Okay. I think Ashok sir has joined. Anyone has seen? If Ashok sir has not joined, then
Sir is busy in meeting. He will join in between.
Okay. Then in place of him, Dr. Parag sir, who is chairperson ICOG, and he is constantly visiting all the 3 days, and he is always present with us. So he will be blessing sir. Sir belongs to Pune. Everyone knows. So
Sir, Kavita, that's okay.
sir,
Don't
just
waste
I
time in that.
request you to bless us, and then we will take blessing from Sarita madam.
Yeah, thank you. Good evening. I bring greetings from ICOG, and it's indeed a pleasure to address the gathering on the third day of certificate course on urogynecology this month. First of all, let me acknowledge presence of past chairperson of ICOG, Dr. Mala Arora. Thank you, Dr. Mala, for being here today. I sincerely thank and appreciate the efforts put in by the conveners, Dr. Kavita Baranwal, Dr. Suman Sinha, and Dr. J.B. Sharma, ably assisted by Dr. Mukta Agarwal, Dr. Meena, and Dr. Sandeep. This program has generated a lot of interest amongst viewers, and even yesterday we had good attendance where registrations had already crossed around 800. So I'm looking forward to a great learning session today. My best wishes for the program and happy learning, everyone. Thank you.
Thank you, sir. So please share CV of Sarita Bhalera madam. Sarita Bhalera madam needs no introduction. She is secretary of ICOG. Yeah. And
I think that's enough, Dr. Kavita.
yeah, and okay, madam.
Yeah.
And immediate past year, AICC, ICOG West Zone, President Mumbai OBG Society, past President AMWI Mumbai branch, past chapter secretary Indian Menopause Society Mumbai chapter. So, madam, I request you. Overall, madam is very active, and I think we could do these programs only because of the first taken by Sarita madam as well as Parag sir. Both are so active and so energetic that we are ready to do every work, everything what they ask us. So thank you, madam, for joining, and please bless this program. Today is the last day of the SUG certified course. Urogynae.
Yes, thank you very much, Dr. Kavita. And at the outset, I must congratulate you and Dr. Suman Sinha and Dr. J.B. Sharma for a really very successful first 2 days. As Dr. Parag said, we've had a fantastic response and to this certificate course, and more people are joining. I do remember on the first day I got panic calls because the capacity was the overloaded, and we had to reset our technical team and increase it to get the capacity. Thank you, Dr. Mala, for being there. And really, on a personal note, I know that it was Dr. Mala who really took me into ICOG, and it's really lovely to see that you're still, very actively part of the program. So I really congratulate the team, and I wish this program all the best. And before I end, I'd like to tell all the delegates that please do register for FICOG. The date is 30th of September. You will get it in Delhi. If you haven't completed requirements, then you can get it in Bangalore in August. So please do that. And we have 2 more certificate courses this year, next month on menopause, and then the following month on oncology, before we end the year and go on to the next year. So thank you very much and all the best.
Thank you so much, madam. So if J.B. Sharma sir has joined, then he will introduce the topic. Otherwise, I will do, because he has written that he is joining, but I don't find him.
No, Kavita. Kavita,
Okay.
please go ahead and
Okay. Okay.
do the work.
So welcome Mala Arora Madam, past chairperson ICOG, and all the dignitaries who are present. Neeta Thakre Madam, Tanveer. So today we have completed 2 days very successfully, and attendance was very high. Very good people have joined, and they have learned a lot from the faculties, both national as well as international. So today the topic is prevention of pelvic organ injury during gynecological surgery by Dr. Tanveer, obstetric fistula by Dr. Meena, and recurrent SOI by Neeta Thakre Madam, who are chairperson Urogynaecology committee, I think before JB Sharma sir. And Mohan C. Regmi is not available. Instead of him, he has deputed someone who will be speaking on urogenital fistula, abdominal versus vaginal approach for management BPA by Dhira, another senior at least expert urogynecologist. OSI, how it can be prevented by Dr. Pankaj Sarwade from Pune. NDVH in difficult situation by Tara Hara Patnaik sir, a very good faculty, and I think vaginal surgeon from Odisha. And Dr. Umarani, also from Odisha, civilly speaking on modified Sarotka's circlage, stitch in time. And Dr. Mohini on hypertonic pelvic floor, causes of management. She's from Batinda. I have seen her. She's working hard in urogynecology. And Dr. Kajila from Singapore, civilly speaking on V notes in urogynecology, what are current trends. So I think all the speakers will join, and we have to follow them, and there will be post-days, and I request all the chairperson as well as speakers to stick on time, because we have limited time, and for that we have to complete in within time. That's why I request all of you, and if there is any query, please put in the chat box and the faculty will answer to the concerned topic. So thank you so much. So now I request Dr. Mukta, she will conduct the scientific sessions. So Mukta is well known. She is professor and HOD of All India Institute of Medical Sciences, Patna. Very active, co-opted member, managing committee IG, founder secretary IG Bihar chapter. She is chairperson endoscopy committee, Patna Gynae Society. More than 80 index publication and 15 book chapters. And recently she has conducted very successful workshop on IG at Rajgir. We have witnessed. So I know she can conduct very well. So I request Mukta to go ahead and conduct the scientific sessions.
Thank you so much, Kavita ma'am, for your encouraging words, and welcome for this first session. For this first session, we have our respected chairpersons, Dr. Mala Arora, Dr. Konar, and Dr. H.P. Patnaik sir. So may I request for the CVs? So I formally welcome my first chairperson, Dr. Mala Arora madam. Dr. Arora is FRCOG, chairperson ICOG 2017, vice president FOXY 2011, editor of the Air Book. Madam is chief recurrent clinics in first trimester pregnancy and hyperhomocystinemia, and Madam is associate editor of Indian Journal of Infertility and Fetal Medicine and peer reviewer of BJOG. Ma'am, we welcome you for this session. My next chairperson is Dr. Hiralal Konar.
Share.
So Dr. Konar is Foxy ICOG 20. FOG, member of the Medical Education Committee. Sir was the former president of Bengal OBGY Society, a very active society. Editor-in-Chief Journal ISOPAP, and Sir was national corresponding editor of our own Jogi. Sir has textbooks are very respectable textbook of obstetrics, textbook of gynecology, and clinics in obstetrics and gynecology. We welcome you, sir, for this academic session. My next chairperson is Dr. Hara Prasad Patnaik. Can we have the CV, please? Dr. Patnaik is MD, MICOG, FICOG, consultant gynecology, and a very good endoscopic surgeon from Cuttack. Sir is ex-Assistant Secretary of Health and Family Welfare, Odisha, Vice President FOXY 2009, Secretary SOFSI for 2015-16, President Association of Obs and Gynae Odisha 2015, Governing Council of ICOG 2010-12, National Correspondent Yogi 2022, and Chair of Geriatric Committee 2008. For state, introduce our first speaker, Dr. Tanveer Singh. Malaman, if you could introduce Dr. Tanveer Singh, please.
Am I muted? Yeah, it is my proud privilege to introduce Dr. Tanveer Singh to you. She is a well-known, sorry, I can't see her CV. Oh yeah, now it's better. She's a consultant at Tanveer Hospital, Hyderabad, Telangana. She's completed research training with commendation at the Harvard Medical School, very prestigious, and Global Clinical Scholars Research Training Program. She is got a level 2 certification in minimally invasive surgery, and she has many awards to her credit: the AAGL IAGE Young Skill Excellence Award, the Foxy Future Award, and the Youth Leader Trophy. She has published extensively, 28 papers, 12 chapters, and one book, and her main interest is minimally invasive gynecology with a focus on office hysteroscopy. Besides this, she is also a marathon runner, which goes to her great credit. Over to you, Dr. Tanvi.
Thank you so much, ma'am, for the kind introduction. And thank you for inviting me for this very good ICOG series, which I've been following, and it's just amazing. So thank you so much for making me a part of this. So without wasting any time, I hope to keep on time, and please let me know if I'm crossing the time. So my topic today is prevention of pelvic organ injury during gynecological surgeries. I have no financial disclosures. So the topics that I'll be going through is very simple: a brief introduction about the entry complications, the bladder, bowel, and possibly touching a few more points on nerve and vascular injuries. So laparoscopy is 41% safer than laparotomy. I think most of you would agree as of today. And it's increasing. And I think India is actually one of leading in laparoscopic surgeons with very good, excellent skills. The overall complication rate is about 0.7 to 6%. And in laparotomy, it's as high as 15%. The major complication rate in laparoscopy is about 2.8%. And what we do understand and what we see commonly also is more than 50% of major laparoscopy complications occur during initial entry into the abdomen. And that is where even I get a lot of calls saying, this is where we stopped. That is the reason we don't do that much. How do we really go ahead? Where do we put our ports? How do we put our varies? Which technique is the best technique? So that's where we're going to talk a little bit about. So why do we want to talk about prevention is we also need to know about complication rates. So the complication rates, hemorrhage, vascular injuries is almost 1.1. Bowel injuries, this is all with mainly laparoscopic. I will try to stick to it because of the time. I would try to stick to only one part of it. So the bowel is 0.5%, urinary tract is 0.7, the wound infection happens is about 0.5%, and pelvic abscess is 0.4. Now, the risk factors is definitely the surgeon's low experience. So I would urge, please go watch as many surgeons as you can, go to many, many different doctors, watch different experts and learn from them. Intraoperative complications occur mainly when the woman's age is more than 38, the duration of surgery is longer than 99 minutes, in cases like endometriosis, DIEs, and frozen pelvis, prior surgeries, and other comorbidities. Post-operative complications occur mainly when the hemoglobin drops intraoperatively more than 2 grams per deciliter, and the American Society of Anesthesiologists status is more than 3. So the entry into the abdomen. As you can see, how can we do it properly? Today, we have more women undergoing cesarean surgeries, cesarean sections, and compared to what we had before. And also, we have more women coming for laparoscopic surgeries with a history of previous surgery. So what do? The best thing you can do as gynecologist is that just put your abdominal ultrasound transducer on near the umbilicus, suprapubic, slide it up there, and ask the woman to deep breathe and just look for the movement of the bowel under the subcutaneous tissue. You can actually see it moving, and sometimes you keep seeing more and more for every case. Your planning is better because you will understand if there are adhesions or not, the omental adhesions or bowel adhesions to the abdominal layer. So that can help you decide whether you want to go supraumbilical or whether you want to go through the umbilicus or through the Palmer's point or through the JN points. So these are the different points which I've put up. You can take pictures and understand how exactly and where exactly you can put your ports. The other preferably is umbilicus. I personally prefer supraumbilical because normally when you're operating, it's usually a large fibroid or a large, the uterine size is much larger. That is where we really go in for hysterectomies or other huge ovarian cysts or DIEs. So that way the vision is much better. And patient should be in a supine position for a Verey's needle. I prefer a Verey's needle, but you can go for a direct entry or for Hassan's technique. And all this requires the patient to be in a supine position. Lift the abdominal wall. Always place a Foley's catheter. That's my personal preference. I know there are some surgeons who ask the patient to empty the bladder and come. For minor surgeries, all right, but for major surgeries, it's preferable to put in a Foley's catheter. If there is high risk of adhesions, yes, use Palmer point or JN point, and always do a safety checklist before starting your surgery with your staff. There is a WHO checklist which is available online. You can just download and use it in your practice. So the tips and tricks are, as you see in the below video, there is some edema. There is, it's not in the right space. The Verey's needle wasn't in the right place. So that kind of disturbs your surgery. It prolongs the surgery and it's not ideal. So you, especially in obese women. So have patience when you're putting in your Verey's. Check that it's in the right position. So in a normal patient, normal BMI patient, use a 45-degree angle, or if it's a very obese patient, then you go 90 degrees. And when you go ahead, once you put in the Verey's needle, do an aspiration test, an injection test, and then you also check on your CO2 whether the intra-abdominal pressure is less than 10 millimeters within 10 seconds. If the pressure is high, then you might not be in the right place. Listen for the double click of the Verey's needle passing through the abdominal layers. Avoid excessive manipulation inside. Once you're in, sometimes you've seen certain surgeons pushing it, moving it from side to side. Please avoid those movements or in and out movements. Just keep it stable and check, do all the following steps. Be cautious of preperitoneal insufflation, which can lead to failed trocar entry, and you waste a lot of time, and then it's kind of puts you off when you're doing the major surgery. I'm not going to go through this slide, but this is for most of them to possibly take it. I found it very nice. Everything in one place where you have the Verey's or the closed entry. Now the direct entry seems to be superior to the other, and now the optical has also come in, and we are using it in practice. I haven't put it up here, but yes, if you have access to optical trocars, you can use the optical trocars, and there is an optical Verey's needle also available today. Which is not come into India, but I know it's already in market in the US. So that's also an excellent innovation. So hopefully it should come, but the thing is they're all disposable. The accessory trocars, always put it under direct laparoscopic guidance. So when we talk about just Verey's needle and the main entry, also the direct trocar also has to be the same way as we have the same rules to be followed, that the patient to be in the supine position, lift the abdomen, do the same rules as we do it for the Verey's needle. Accessory trocars is under direct laparoscopic guidance. Place trocars almost 2 to 3 centimeters above the anterior superior leg spine. I would also like to talk about the later about the maybe nerves and the injuries if we have the time. Inferior epigastric vessels injury is about 0.3 to 2.5%, and it mainly comprises 48% of all vascular injuries. So make sure that you identify the epigastric vessels if you can in thinner patients. The more and more you do in normal patients, you get more experience and put it in the right place so that you don't land up in complications of vascular bleeding. Yeah, this is where I've already put it up. So this is a very common injury, and post-operative women come and complain about sharp pain in the suprapubic area, labia, and the thigh. There is paresthesia, and sometimes pain relief is after local injection. So ideally, you place your trocars almost 2-finger breadth, as we say, and above and medial to anterior superior leg spine to prevent the iliohypogastric or ilioinguinal nerve injury. Coming to bladder injury are most common visceral injuries. They comprise about 0.03 to 0.2% of cases. And the causes are, the risk factors are the prolonged monopolar use of energy, improper uterine manipulator placement, and suprapubic trocar entry. Well, a lot of people don't use a manipulator, but I would really say if you're starting off early in your career, please use a manipulator. It really, really makes your surgery easy. Now, these are two different videos. You see in the first video on the top, there is a bladder burn. At the end of this procedure, like a complex surgery, sometimes when you're dissecting the bladder down, there was a bladder burn, and we identified it intraoperatively after, by doing a cystoscopy. So especially, there is no consensus on doing a universal cystoscopy in every benign gynecological surgery. But if you think it's a complex surgery, then you must do a cystoscopy so that you can identify and you can treat these bladder injuries then and there. Either leave a catheter in for about 14 days or longer than that, and then you follow it up, and then, or you can also repair it depending on whether it's been treated or not. The second case, you see the dissection is not proper because the cup was not totally in the manipulator, and there you see there is a bladder injury on cystoscopy. This was much earlier in my career, so I wanted to put it up for the youngsters, because sometimes when it's very bloody and you don't really see, you go on dissecting and cutting without really realizing where you're doing it. But if you have done a cystoscopy, complications do occur in surgeries, but it's important to diagnose and follow certain steps. Don't skip the steps when you're operating, and that's where you'll be able to identify. So we went back, I called in a urologist, but we did suture it in 2 layers. And there were 2 injuries on the bladder, which I had cut at different places. It was a very badly stuck bladder, and that is the reason why there was an injury, and it can happen, but it's important to diagnose and treat because the morbidity is very high. So the other thing I also want to say is complex surgeries such as your DIA or endometriosis surgeries, when you actually do the pararectal spaces, you happen to sometimes injure the nerves that are present over there, the S2, S3, S4s, and you have to be very careful when you're dissecting in those areas because there can be a long-term bladder dysfunction or urinary retention, which many of them complain of. And you just got to be more conservative in management and explain to the patient that they resolve in 9 months, but be careful when you're dissecting in those areas, unless if it's unavoidable, and then you explain to the patient. So another video on the importance of cystoscopy. Again, this was a long surgery, huge fibroid. There was some bleeding. And at the end, it was also about just when I started off doing my lab surgeries. I'm sorry, I'm showing all the bad videos. I thought it's important to show the importance when you're early in your career. So there I go. I was extremely tired at the end of it, and I wanted to finish suturing. And there you see the suture goes through the bladder. And if you just go ahead, finish, close the vault and come off, and you don't do a cystoscopy, which actually in my fellowship, this was my study to do a universal cystoscopy. There I find a stitch through the bladder. Now I just went in with the scissors, cut the stitch, and then went back in and actually removed that stitch from both sides. I also cut it through cystoscopy. Sorry, the video just went away. But the other one was take out this and again resuture it. Identify the planes correctly and resuture. So I think that's the most important thing. This was a more recent surgery that I've performed. So I think preoperative catheterization, I do believe in it strongly. I know some surgeons don't, but it's your expertise and your confidence. Expose the bladder, identify the cleavage pain, the pubocervico-vesical fascia. You must identify, go slow. If you go slow, you can be really fast in your surgery. The more I do, that's what I realize more and more. So traction and counter traction, ask your assistant to give a counter traction, proper counter traction. Have a uterine manipulator inside. I use the Stores manipulator, the Mangeshkar manipulator, and I'm very happy with it because it gives me, the bladder is just pushed up and it's easier to dissect the bladder out. And ensure that when you use this during colpotomy, it ensures a safe distance, reducing bladder injury and fistula risk. So that's the bladder dissection. Also, you can go from the lateral window and medially do the uterines, come from the lateral window and go medially and dissect the bladder. I'm just going to rush through this. And sometimes make sure it's possible that you cut the cervix more. That's also possible. So be careful because then it keeps bleeding and you're wasting time. So find the plane. The cleavage plane is extremely important. Initially, I was in a good plane, then I went a little low down because it was adherent and I went into the wrong plane. Then I went ahead and corrected my plane. So ureteric injuries, the most common location of ureteric injuries are the uterine artery, then comes the IP ligament and the uterosacral ligament. The overall incidence of ureteral injuries is 0 to 2.2%. So the risk factors are deep infiltrating endometriosis, large uteri, hysterectomies, and excessive bleeding. So counseling to the patient is extremely important, especially when you're dealing with difficult cases and what could be. You don't have to scare them off, but you can just very casually mention that some injuries can occur, but don't worry, we are there to handle it. We will look after it. So this was one case of endometriosis. Look at the top video. Look at this video where we literally had to call in a surgeon, and we did put in a stent later. But I just wanted to show that this particular case, there was ureteric implants, endometriotic implants. There was a nodule there, and also there was hydronephrosis. And this actually we were confused which one was the ureter. Again, this was a couple of years back. And there you find it's actually an artery, and this is the ureter. So when you do a lot of dissection, it can lead to complications and thermal damage. This patient was okay, but we obviously she's on medical management. And the other problem that can happen is if you dissect too much around the ureter, there can be devascularization. Now, this particular case, ideally where you see at the pelvic brim, that's where you start the dissection and you go lower down so that you can find a proper plane. So now we know better. There we tried initially to dissect and later we came up and then started dissecting from the bladder. So now we know better to dissect up where it's clear and then you go down. So the tips and tricks are ureter identification, use pyridium. I've not given it here, but indigo carmine is ideal, but we in India don't have indigo carmine. I don't know if somebody is using it, can let me know, but I use pyridium at times where you can see an orange color urine coming up in the bladder, the spurts that go in one night before, even early morning. And then during hysterectomy, you can fenestrate the broad ligament, isolate the uterine artery. You can also isolate the ureter. I mean, you don't really have to do ureterolysis, but for identification of the ureter, you can do a lateral approach, a superior approach, or a medial approach where you
Sorry
can...
to interrupt you, ma'am. Your time is up.
Okay, then I will stop. Right, so I just wanted to talk about bowel injury, but sometimes you can have a bowel injury. Tip is use bowel graspers and avoid prolonged contact. So thank you. I won't take too much of the time.
Mala ma'am, you are muted.
I'm sorry. Thank you, Dr. Tanveer. You have shown us very, very good videos of complications, which not many people present to juniors. And we have all been through these complications in our learning curve. It is so very important to recognize it on the table and correct it.
Yes, ma'am. So I very strongly believe that I can always show the best of the videos because there are some good days and there are some bad days. But in our forum, if we don't really talk about complications, the juniors are going to be very scared to take the step ahead. So that is the reason I try to show some of the worst videos that I have done, or, you know.
That, but you do have a few questions in the chat box.
Yes, I will answer it as we go ahead, ma'am. You can go ahead with the.
Yes. So in bowel injury, how do you proceed?
Yes. You want me to answer here, or would you like me to answer them
Answer the
separately?
chat box. Yeah, maybe it's better you answer in the chat box.
I will do that. Yeah. Thank
Okay.
you.
Thank you so much.
Thank you, Dr. Tanveer. Thank you, Dr. Mala Arora, madam. I will invite Dr. Hiralal Konat to introduce our next speaker and her topic.
Sir yet to join. Hiral Kora yet to join.
Yeah. So, Mala ma'am, if you can introduce our next speaker, Dr. Meena Mahalingam.
Our next speaker is Dr. Meena Mahalingam. She is MD, DNB, MRCOG, FICOG, MNAMS, and FAGE. Very highly qualified Associate Professor of Obstetrics and Gynecology in Chingalpet Medical College and Honorary Secretary OXY, co-chair of the Urogynaecology Committee of OXY. So she's a member of the Urogynaecology
Thank
Committee
you, Mala ma'am.
of OXY as well.
Thank you, Mala ma'am,
Welcome,
for the
welcome.
kind introduction.
Okay.
Madam, can I share my screen?
Yes. Can we allow her screen sharing, please?
Is my screen visible?
Yes, ma'am.
This
It
is
is.
Full screen, ma'am.
Yeah. Is it coming full screen?
No, it's not on screen. It's not
Yeah.
on full
You go
screen.
to the slideshow mode, ma'am.
Yeah. Now is it coming full screen, madam?
No, ma'am.
no, it's not yet coming full screen.
The first from current slide. Now?
No.
Ma'am, click on the slideshow mode. मैम ऊपर
Yeah.
की साइड में है देखिए आप हाँ from beginning from current slide ma'am.
Yeah. Is it coming full screen?
No,
Yeah.
ma'am. Ma'am, click on the from beginning.
Yeah, just a minute. Is it coming now?
No, ma'am.
No.
I'll just stop share and reshare now.
Yes.
Nilima, is it coming as full screen now?
No, ma'am.
No.
Can I share?
Yeah.
Okay.
First, click the start slideshow.
Stop share.
Yeah. Nilima, are you doing or shall I do from my end
She
itself?
is doing, ma'am.
Thank you, and sorry for the technical glitches. Thank you, Nilima, and thank you, Mala ma'am. Thank you, ICOG team, for having given me this opportunity. Dr. Kavita ma'am, Suman ma'am, and JB Sharma sir. So my topic is about obstetric fistula. Does it still exist in the modern era? So as we all know, it is abnormal communication between the genital tract, urinary tract, and the rectum. So 90% of the fistula in developing countries are due to obstetric trauma. It occurs due to ischemic necrosis of soft tissues of the birth canal due to prolonged obstructed labor without timely intervention. Next. So, exclusively it is seen in low resource settings where access to skilled obstetric care is limited. WHO estimates of about 50,000 to 100,000 women developing obstetric fistula annually worldwide. 2 to 3.5 million women in developing countries are affected. Next. So highest prevalence is seen in sub-Saharan Africa. Next, we see in India, that is South Asia, 0.08 to 2.7%. In India, despite having economic growth, the prevalence is around 2.2 to 7. In between 0.3 to 7.6% based on community surveys, which are not going to be highly useful, but having a highest prevalence in Uttarakhand, about 3.4%, especially in the rural areas. Next, and obstetric fistula accounts for 6% of the maternal mortality. Now, why does it persist in the modern era? Next, so we need to understand the 3 delays which the rural women are facing. Delay in decision to seek care, failure to recognize prolonged labor or obstructed labor, lack of women's agency, especially the attenders in decision making, and fear of healthcare facilities and surgical interventions. Economic constraints limiting to access to healthcare. Next. Delay in reaching the healthcare, poor transportation infrastructure. Some women do not have a facility to come from their rural area to the tertiary care center, geographical barriers in rural and remote areas, financial barriers to travel and accommodate. Delay in receiving treatment, especially insufficient skilled birth attendants, inadequate emergency obstetric care facilities, lack of surgical capacity for cesarean sections. Next. Risk factors. 85% of women with obstetric fistula were married before the age of 18. There is a prolonged obstructed labor, early marriage and early pregnancy, lower socioeconomic status, poor educational levels, malnutrition, short stature, especially the literature quotes a height between 149 and 156 centimeter, and an average Indian height is around 150 centimeter. Limited access to emergency obstetric care, inadequate antenatal care, prolonged or neglected labor and instrumental delivery. Application of forceps at the later stages especially can cause a obstetric fistula in the form of either a VVF or a rectovaginal fistula. Next. In a retrospective of study of 93 patients treated for obstetric fistula in central Uganda, the average time spent in labor was 2.56 days with average delay of 1.36 days in seeking medical care. So pathophysiology, as I already mentioned, the obstructed labor, prolonged compression of the vaginal wall between the bladder base, urethra, vagina and the rectum between the 2 bony prominences, the fetal skull and the maternal pelvis, anteriorly the pubic symphysis and posteriorly the sacral promontory, thereby impairing the blood supply, causing ischemia, necrosis of the tissues. Thereby, after 3 to 10 days, the necrotic tissues usually slough off, leading to fistula formation. Next. So, necrotic slough extruded through the vagina can be seen usually in these women who have had a difficult labor. There is a urinary leakage or a true incontinence. They keep continuously leaking urine, and incontinence of feces or flatus through the vagina when there is a rectovaginal fistula. So primarily they tend to have a secovaginal fistula or a ureterovaginal fistula. Ureterovaginal fistula, which we have shown using a metal catheter pass through the urethra coming out through the fistula site, or the rectovaginal fistula, and the levator-ani complex weakness, neuropathy and muscle loss. Peroneal neuropathy, unilateral or bilateral foot drop, and bony abnormalities having bone spur, resorption, separation or obliteration of pubic symphysis. Next. So the secondary signs, usually they have a lot of social stigma. They do not even able to mix in the social crowd. They have affected mental health like depression, stress, anxiety, limb contraction. They do have malnutrition, leading on to later upper renal tract damage, developing a bladder stone. Herein we can see a urinary dermatitis and a prolapsing bladder through the fistulous tract, and reproductive outcomes. Consequences, there is a high maternal mortality rate of 14.4% in women with obstructed labor and a perinatal mortality of 26.4% among affected pregnancies, and 90% of the women with obstetric fistula, they deliver stillborn babies. So the mother has also a maternal mortality as well as social problem affecting her dignity or the quality of life, and the baby also is lost. How are we going to manage? Taking a detailed history and examining, especially a digital examination after a speculum examination of the vagina to identify the fistula site, size, amount of scarring, and usually a 3 swab test wherein we place 3 swabs, upper end, middle and the lower end, which was previously done. As Tanvir was saying, we do give pyridium because non-availability of indigo carmine and a methylene blue dye injected through the bladder. So the staining on the upper swab identifies a urethral injury, and the middle swab usually identifies a bladder connection, that is a vesicovaginal fistula, and the lower staining of the swab indicates it is a urethral fistula. And especially cystoscopy helps in identifying the type of fistula, the size, the closeness to the trigone, whether it is a supratrigonal fistula or a trigonal fistula. And localization of the fistula is very much important to do a proper classification. If there is a ureteric involvement as uretrovaginal fistula, they tend to do a CTIV, which is gold standard to identify the exact size of uretrovaginal fistula. Next. So these are two classifications. The GO classification, which tells based on the site, the proximity from the distal edge of the fistula, whether it is more than 3.5 centimeter from the external urinary meatus. Type 2 is 2.5 to 3.5 centimeter. In type 3, it is 1.5 to less than 2.5 centimeter. In type 4, it is less than 1.5 centimeter from the external urinary meatus. And the size A, B, C is less than 1.5 centimeter in the largest diameter. B is 1.5 to 3 centimeter in the largest diameter. C is more than 3 centimeter in the largest diameter. Based on the scarring, it is 1, 2, 3, none or only mild fibrosis. Moderate to severe fibrosis is 2 when there is a urethral involvement or circumferential fistula. Similarly, there is a classification of the genito-anorectal fistula. The same applies based on the size, site, and scarring. Classification is the next slide. We have the WHO Valdigit clinical classification widely used in obstetric fistula programs, wherein the type 1 fistula is not involving the continence mechanism, that is not involving the urethra or the external sphincter. In type 2, the fistula involves the urethra and the continence mechanism, and type 2A without complete urethral involvement. 2B is with complete urethral involvement, and type 3 miscellaneous type exceptional involving the ureteric or the vesicouterine types. Next. Now, how are we going to manage these fistulas? The next speaker is going to deal in detail. So I would be dealing the conservative management, wherein we are going to do for small fresh fistulas, the conservative management with just a catheter drainage for 4 to 6 weeks achieves 40 to 95% of spontaneous healing rates. Next. Surgical management, we do have the vaginal repair, abdominal repair, minimally invasive techniques like laparoscopic and robotic. In the vaginal repair, where the mobility of the vagina is good and we have adequate exposure and it is a low fistula, we go for a Latz-Coast procedure, where we do identify the area and keep stay stitches using silk or vicryl, and we identify the fistula site and make a circumferential incision, dissect the bladder and the vagina well away, keeping 2.5 centimeter free vaginal area, and then closing the bladder area with the 30 vicryl sutures and overlaying vaginal pubovesicocervical fascia over it. In fact, we can keep a Mauritius fat pad flap. If there is a very thin area of suture, we can keep a Mauritius fat pad flap. The layered closure, usually they say transverse closure of the bladder, then vertical closure of the vaginal walls. And the abdominal repair, where there is a O-corners repair, wherein we are going to do bivalving of the bladder and then repair the bladder fistula site and then placing a omental flap as an interpositioning flap. Minimally invasive nowadays, laparoscopic and robotic have really helped in this fistula repairs. Next. So this is a fat pad flap wherein we have mobilized the fat pad from the labium majus and brought out through the tunnel and placed over the fistula site as a overlaying flap. Next. So the principles: flap splitting technique, exposure of the fistula and protection of the ureters, wide mobilization of the bladder from the vagina, cervix and uterus surrounding tissues so that there is no tension on the bladder mobilized area, and tension-free closure of the bladder is of utmost importance. 2 to 3 layer closure is important, and dye test to confirm watertight closure of the bladder. These are the techniques to close the vesicovaginal fistula. Next. Prognostic factors. So how are we going to get a consensus to know whether the take of the stitch has happened? whether it is close to the urethra, whether there is severe vaginal scarring, the size of the fistula, whether it is closer to the trigone or the supratrigonal area, amount of bladder tissue loss. And time of repair, usually we plan 3 months after injury because the necrotic tissue takes time to slough and suboptimal tissue that remains to recover before attempting to operate. Next. So post-operative care, usually a continuous bladder drainage for 2 to 3 weeks, antibiotics, high fluid therapy, laxatives to prevent constipation, mobilization, social rehabilitation and reintegration. Complications, usually there is a recurrence or residual incontinence, urinary retention, frequency and voiding dysfunction. Sexual and reproductive complication especially affects the social and mental health of the particular affected women. Next. So clinical outcomes and management challenges, modern surgical techniques achieve overall success rate of 88.1% for obstetric fistula repair. However, significant challenges remain. Repair failure rates average 24.92% across sub-Saharan Africa. Complex repairs show only 10% success rate compared to 95% for simple repairs. Previous repair attempts reduce the success by 47%. Next. So prevention strategy, the primary prevention is universal access to skilled birth attendants, antenatal care integration, availability of emergency obstetric care like doing a timely cesarean section, use of partogram to monitor the progress of labor, indwelling catheters in obstructed labor cases so that if there is a intention to form a fistula usually gets healed by this conservative management. Next. Coming to the secondary prevention, early recognition and referral to a tertiary center, training the healthcare workers in danger sign identification, implementing birth preparedness and complication readiness programs, community health worker education for early screening of these cases. Next. So WHO Sustainable Development Goal 3.7 aims to ensure universal access to sexual and reproductive healthcare services by 2030. So fistula eradication by 2030 is a component of this objective requiring immediate coordinated global action. To conclude, obstetric fistula not only exists in the modern age, it thrives where modern obstetric care fails to reach those who need it most. Obstetric fistula is preventable, treatable, and eliminable with safe motherhood and strong health systems. Next. International Day to End Obstetric Fistula was created as a global call to action every 23rd May to raise awareness and support for affected women and girls. Thank you for the wonderful opportunity.
Thank you, Dr. Mahalingam. I request respected chairperson to introduce the next speaker for the session, Dr. Neeta Thakre, and Madam will be speaking on recurrent SUI causes and management. Mala ma'am or Dr. Patnaik?
Okay. Now I must thank the speaker for giving us a very good insight into the obstetric fistulas, and I would want her to answer the questions in the chat box as well, please. And now it's my great pleasure to introduce a very dear friend, a very talented obstetrician, Dr. Neeta Thakre, who's the president of the Ahmedabad Urogynaecology Society and president-elect, who's also held posts of honorary secretary, joint secretary, and West Zone coordinator of Team Foxy in 2020. She is the Foxy Urogynaecology Committee chairperson from 2017 to 19, and she's an ex-assistant professor at the IKDRC Medical College, Ahmedabad. Her special interest has been both urogynecology and high-risk pregnancy and gynae endoscopy. And she's director, WellCare Hospital, Ahmedabad. Over to you, Dr. Neeta. I won't take up too much time.
Thank you, Mala, for that kind introduction. Thank you, Dr. Hara Patnaik and Dr. Kornar, who are co-chairs for my session. Thank you, Dr. Parag Biniwala and Kavita Banwal, for inviting me. And it's an honor to contribute to such a well-organized and meaningful ICOG series. I truly appreciate the opportunity that I shared to get this insight for this topic, which is very close to my heart. And I'm happy that I will be able to engage with such a thoughtful attendees. I think numbers were really great yesterday and day before. and I'm hopeful that today also it is the same. So my topic today is recurrent stress urinary incontinence. I would be reevaluating. Can Shreya, are you sharing my screen?
Yes, ma'am.
My presentation rather?
Yes, ma'am.
Yeah. So my topic today is recurrent stress urinary incontinence, a challenging situation where we will be reevaluating, restaging, and retreating. So let me tell you that stress urinary incontinence is one of the most common pelvic floor disorder we treat. And mid-urethral sling revolutionized the management. But the story doesn't end there. At long-term follow-up, it is seen that almost 20%, 20 to 25% of women report recurrent urinary incontinence after the primary sling worked for some time or maybe it did not work at all. And out of those 25, 15% will require additional treatment. So that is what is seen in a Cochrane study. So according to epidemiology and the burden of this disease, it is seen that 20 to 25% recurrence rate, and the recurrence may be either recurrence or it is persistent urinary incontinence which never got treated. So we have to make sure whether the patient is having what kind of recurrence. And it is seen by some studies that 1 in 4 had recurrent urinary incontinence because they followed these patients for about 17 years after mid-urethral sling. The Cochrane review confirmed the recurrence is consistent across the multiple trials, and out of them, as I told, 15% required resurgery or some reoperation within 10 years. So we have to make sure that we explain our patient that there will be lower outcomes when we do a redo procedure. And recurrent SUI creates significant decline in quality of life, affecting mental health, sexual health, and daily functioning of our women patient. What is the definition? A difference between persistent and recurrent stress incontinence. In persistent, the leakage continues. It never got it right at the first time. Can you change the, someone is changing the slide? Hello?
Yes, ma'am. May I?
Yeah. Yeah. So, thank you. So, in persistent stress urinary incontinence, the leakage continues immediately after primary intervention, and it suggests that there was a technical failure or misdiagnosis, and it requires immediate reevaluation. In one of my patients, I entered on the day 3 when she said that I have no difference in after the surgery, and I had to just tighten the sling which I had put in, and the solution was there. So it was a persistent SUI. And for a recurrent SUI, initial improvement is seen, and then it is followed by a symptom return. And there can be some progressive factors which may be responsible, like aging, intrinsic sphincter deficiency, or prolapse for that particular patient. And in recurrent, the procedure worked initially and then failed later. And more often, it is a progressive functional change, as I already explained. In both the group, uh, there are many studies, but we as clinician, this distinction matters because in redo choice depends on whether it was never fixed or it is relapsed later. So we have to find out the difference. In etiology and risk factors, let me explain. There are anatomical or technical, functional or patient related risk factors. In anatomical risk factors, there is improper sling tension or placement, as I already explained. The mesh may have got degenerated, or there might be mesh erosion, malposition, and maybe the technique which one chose for the patient was inadequate. In functional, there might be intrinsic sphincter deficiency, which can be found out on urodynamic study, poor urethral coaptation, urethral hypermobility where there is inadequate support, or missed detrusor overactivity, or there might be a missed urinary incontinence and we have not checked the urge part of it. And patient-related factors can be obesity, diabetes, smoking, previous pelvic surgeries, prolapse progression, or collagen weakness and hormonal changes. From all this, what we can say that failure are not always surgical. It may reflect patient physiology as well. And we have to find out whether patient is having intrinsic sphincter deficiency or hypermobility, and we have to phenotype this pattern, and that's how we can decide the redo surgery which is best for and tailor made for that particular patient. And technical errors like tape too loose or too tight, wrong plane, etc., are explained in early persistence, but tissue related changes are explained in late recurrence. And risk amplifies with obesity, diabetes, smoking, all these factors, because it worsens the sling success rates. And I would like to say that if you don't phenotype the urethra, you are operating a blind in redo case. So don't ever not phenotype or evaluate in a proper way. So how do we evaluate? What is the workup that we need to do? Comprehensive history, which is very, very important. We have to see the symptoms, its onset, severity, what is the leakage pattern. We have to see the quality of life assessment, the questionnaire that we have to give it to the patient, and also what was the previous surgical procedure that was offered to her and done in her case. You have to do proper physical examination, all the cuff stress test, urethral hypermobility assessment, vaginal atrophy, scarring, prolapse, all those factors we have to see in examination. And also look for pelvic floor muscle function. Urodynamic is very, very important. In primary surgery, in pure SUI, you may not do urodynamic study, but when you are offering a patient in a recurrent case, you have to do urodynamic study and establish the phenotype of the problem, and then only offer the treatment. Advanced imaging like perineal, yesterday or day before yesterday we were discussing perineal ultrasound, introital ultrasound, which will tell us the tape position, MRI in selected cases, and we must do urine analysis, post-void residual urine estimation. So that is very, very important. So risk, let me tell you, so now coming to non-surgical management of recurrent exercise. So primarily, whenever patient comes to you, you are not going to offer her directly surgery. You may not, rather. So pelvic floor muscle training may work in some patient. It may reduce the leakage. It may have limited effectiveness after failed surgery, but it remains first line of conservative management. Second is conservative management is bulking agent, which is indicated for intrinsic sphincter deficiency or those patients who are not a good patient for surgical intervention. And you have to provide symptom improvement. It provides symptom improvement, but it won't give you complete continence. And pessaries and device are adjunctive therapy, which can be offered to patients who are not ready for surgery. So we, what is non-surgical surgical options? They are bridges and not cures. Best for frail, elderly, and risk-averse patients. And you have to give them this option only when they are not ready for the surgery. But you have to tell them that dryness rates are low with this, and durability of these procedures are also very short-lived. And the pearl here is that bulking is a tool and not a redo solution. and you have to set an expectation which is accordingly, like you have to explain the patient. So you can't have the patient have a very high expectation from these non-surgical management options. Now coming to surgical redo. Here, let me tell you, mid-urethral sling is the best option for all these candidates, especially for those who are having intrinsic sphincter deficiency phenotype, prior if they have undergone transobturator and that has failed, if there is a persistent urethral hypermobility and there are good quality tissue available, then the success rate is almost 60 to 80%. And let me tell you, mid-urethral sling, I'm in favor of retropubic, and the literature also says the same, that retropubic variety of mid-urethral sling will give you better success rate. So repeat mid-urethral sling is the workhorse for redo surgery, and meta-analysis also show that redo mid-urethral sling can be nearly as effective as primary. And it is very important that you have to make the phenotype very clear by evaluating the patient very nicely. Approach consistently the three varieties is very of in contact. And it emphasizes we have to say that if first was transobturator, then failed has to be retropubic. Okay, so that is very, very important. Coming to other surgical redo options, they are autologous facial sling, Birch colposuspension, and artificial urinary sphincter. So for autologous facial sling, it is a strong duration from patient herself, and its best controversies. It is excellent for intrinsic sphincter deficiency, and it requires longer recovery and more. You have to tell the patient that there are chances of more voiding dysfunction risk. For Birch colposuspension, let me tell you, this is historically gold standard treatment where there is no mesh used, but the morbidity for the patient, because it's an open surgery, or if you're good at laparoscopic Birch, then maybe it is less intervention, but that is morbidity is more and usually offered with patients where there is some other treatment, abdominal procedure is also expected, or if you are doing it in a case where there is a huge prolapse, so you can offer Birch colposuspension for the same. In artificial urinary sphincter, we have to offer to the patient who are having end stage sphincter deficiency, and it needs long term counseling, and revision rates are high. That's what we have to explain to the patient. So you have to think that AFS is for ISD, Birch is for hypermobility and prolapse, and AUS, that is artificial urinary sphincter, is for when there is nothing else which works. Now let us discuss phenotype driven management algorithm. So what are the phenotypes that you have to see? Whether patient is having ISD, whether a patient is having hypermobility, or there is mesh complication because of which she has she is having recurrence, or what is the just a minute, what is the issue with the patient? So reevaluate the diagnosis, identify the phenotype by doing urodynamic study, and then step 3 is tailor-made management. In ISD, offer redo retropubic midurethral sling or AFS. Hypermobility, you have to give them option of redo retropubic or Birch. And in MASH issues, please first treat the MASH which is eroded the bladder or maybe urethra or whatever, and then offer another procedure. And in severe refractory cases, artificial urethral sphincter is the best consideration. So offer that. So that is very, very important to take home message. And here we have to say that redo what the patient's physiology needs and not just what you are comfortable doing. Okay. So depending on the phenotype, you have to offer the options. Controversies and counseling in recurrent stress urinary incontinence. So in urodynamic, it is strongly recommended in redo cases, and in bulking versus redo mid-urethral thing, you have to say that bulking is safer, less invasive, and lower durability, and redo is higher cure rate and more invasive approach. So we have to offer this cafeteria approach we have to do with the patient and offer all the options to the patient. So in current evidence and guidelines, it is said that retropubic is superior to transobturator approach in intrinsic sphincter deficiency and recurrent SUI management. Mesh safety is a concern which has highlighted a role of non-mesh alternatives like autologous mesh or autologous tissue rather, not mesh. And patient counseling must address lower success rate in revision surgery and go for individualized approach. Okay. So controversy in guidelines are there, but you have
Sorry to interrupt you, ma'am, but your time is up.
Oh yeah. Can I take another 5 minutes? Or I come to conclusion, that also is fine. Hello, Mala?
Yes, ma'am. Please go ahead.
Yeah. So you have to take the chance for the patient-centered decision. Now, coming to pearls for practice. So what you have to do, stage the diagnosis before reoperation, do urodynamic study, match treatment to phenotype, as I've already discussed, for ISD, retropubic, for hypermobility, retropubic or birch, and address the mesh issue first and then offer the surgical treatment. Set realistic expectations, and shared decision making makes the life easy for us. So honest counseling is very, very critical. Redo outcomes are good, but not as high as primary. And here we have to say, I have to say that redo SUS surgery is not just about skill. It is about judgment, counseling, choosing the right operation for right urethra. Thank you so much for patient hearing. And I think this is
Dr.
what I
Deepa,
wanted to
it
convey.
was an
Yeah.
excellent presentation for recurrent SUI, and I was listening to you from the beginning, and it was really very, very good. And I really appreciate the way you have presented it. And if time have permitted, you could have shown some videos as well. But it's very good for the young gynecologist to learn, particularly recurrent UTI. All the three speakers in this session have done extremely well. I wish them good luck, and thank you very much. We can close the session now.
Thank you, Hara sir. Thank you for those positive comments.
Very nice. Very nice.
Thank you. Thank you, speakers, for very lucid presentations. Thank you, chairpersons. And now we will move on to the second session of today's course. And that can we have chairpersons for this session? For chairing this session, we have Dr. Rekha Jha, consultant obstetrician and gynecology from Bhagalpur, Dr. Komal Chavan, and Dr. Shobha Gudi. Can we have the CV, please? Jha is President IMA Bhagalpur, and he is organizing chairperson for 2 conferences, and she has been serving Obstetrics Gynae Society. I welcome Dr. Komal Chavan. Dr. Chavan is MD DNB FICOG. Can we have the CV of Dr. Komal Chavan, please? Yeah, thank you. Dr. Komal is Vice President Foxy 2025. She has many prizes and awards to her credit, which is Foxy Women Empowerment Award, Foxy Dhira Award, Dr. D.K. Tank Award, and many organizer of many conferences, Wonder Foxy Award, Champions of Foxy Awards, and she is Medical Director of Chavan Medical Maternity and Nursing Home and a Senior Consultant, DNB this session. Can we have the CV slide for Dr. Team, can we have next CV slide? Thank you so much. So next, I would like to welcome Dr. Shobha Guri. Madam is Professor HOD from the Bangalore. Madam can we have the CV slide? Please don't move. Thank you so much. Madam is a revered postgraduate teacher and the examiner, chairperson, Family Welfare Committee, Foxy 1922, President BSOG 1819, assessor of GOI project Lakshya GCM ICOG 21 to 25, national corresponding editor of Jogi, board contraception and reproductive health ISOPAP 23 to 25, executive committee member of Kasoga, editor of obstetric hemorrhage, author of many Foxy Focus, and madam has many national international publications. She is awarded with the CL Javeri Symposium 2015 and Sri Satya Sai Foundation Community Service Award, Distinguished DNB Teacher Award 2019, and MS Signature for Unparalleled Contribution 2020. We welcome madam for this session. And I would like to request the chairperson to introduce our first speaker, Dr. Patnaik.
Can
you hear me? Can you hear me now?
Yes.
Yes, ma'am.
Can you hear me? Yeah.
Yes.
Yes. Good evening, sir. Good evening, Patnaik, sir. Good evening. It's an absolute privilege to be here, and yeah.
Thank you. Thank you, madam.
Okay.
I can.
I can go ahead. Achha. Can you show me the CV?
Yes.
Let me. I'm really delighted to be here, and certification course is such a wonderful. I have been following it for the past 2 days. A lot of learning is happening, even for seniors like us, and it is a real no matter of prestige that Hara sir is going to speak today. Can I have a CV? I'm not able to see the CV, please. नहीं दिख रहा मेरे को. दिख रहा? Can anybody see? You have not?
Yeah. It is on the screen, madam.
Oh,
it's okay, madam. Dr. Kabir, it is all right. That's all that you know me, and I can start my presentation. No issue.
Just a minute. Anybody else is there? Komal, आप हैं तो आप कर दीजिए. मैं बाद में कर देती हूँ. Yeah. Anybody else is? I don't know why I'm not able to see. I think.
Hello. Yeah, I can see also. Can you hear me?
Yeah, please. Please. Komal, go ahead.
Yes. So it's a great pleasure to now welcome Hara Patnaik, 2009, Secretary General of SOVSI and President of Indian Menopause Society, the past president. And it's a very
thank you.
In so many workshops, and traits all the skills and everything, and I have whenever we workshop all the audience and off with this. So
thank you. It's a pleasure to have such wonderful chairpersons, Dr. Rekha, Dr. Komal, and Dr. Shobha Gudi, esteemed teachers. Thank you, Foxy. Thank you, Parag, the chairperson, and the team ICOG 2025. Can I share my screen? I really thank
Yes.
Where is my... Yes. Can you see my presentation? Hello?
Yes, sir.
Are you able to see me and see my presentation?
Sir,
Please say yes or no. Is it moving?
No, sir.
It is not moving?
No.
How do I do that?
Sir, open your presentation and then share.
I have opened the presentation.
No, that files we can see only, sir. Just open presentation and then share, sir.
Open the presentation.
Yeah, correct. Now it is sharing and share that. Yes,
All
coming.
right.
Yes,
You
yes.
are coming?
Coming.
Is it moving?
Just go to the next slide, sir.
It is not moving.
No.
सर आप आपका पीपीटी पहले ओपन करके मिनिमाइज कर दीजिए सर, ये आपका
पीपीटी
स्क्रीन
ओपन
दिख
करके
रहा है।
मिनिमाइज
Yes,
किया था
सर। अभी आप शेयर स्क्रीन में जाइए सर।
और एक बार
हाँ, आपने
शेयर।
मिनिमाइज किया है ना सर?
यस, मिनिमाइज किया है।
हाँ सर, अभी आप ये ग्रीन एरो जो दिख रहा है शेयर, उस पर क्लिक कीजिए।
किया। ये पहले विंडोज खोलेंगे।
हाँ, आपका प्रेजेंटेशन दिख रहा है सर वहां सामने?
हाँ, दिख रहा है।
हाँ सर, उस पर क्लिक कीजिए। हाँ,
क्लिक किया।
हाँ सर। फिर स्लाइड शो सर, अपर
स्लाइड
साइड।
शो
हाँ,
आया।
स्लाइड शो पे क्लिक कीजिए सर। हाँ सर, नेक्स्ट स्लाइड
आया।
हाँ, यस सर, परफेक्ट।
Yes, go ahead, sir.
Thank you so much. It's really a problem. You will all be surprised to know that in 1825, James Johnson in London Medical Surgical Review wrote that we consider extirpation of uterus not previously protruded or inverted one of the most cruel and unfeasible operation that ever was projected or executed by head or hand of the man. He meant to say that if uterus has not come out or protruded out, do not think of removing it by pulling it out through the vagina. And we are very far from discouraging bold and untired operation, but there is a limit beyond which it may not be prudent to go. Can you know that? And 150 years later, hysterectomy, vaginal hysterectomy, has become the commonest operation. Well, today, vaginal surgeons, gynecologists tell that give me any size of the uterus, I will be able to remove it vaginally. That's the change from 1825 to 2025. Well, I'll be speaking of some difficult situation in non-descent vaginal hysterectomy. You do not use the word non-descent, it is vaginal hysterectomy for a non-prolapsed uterus. We know that hysterectomy is a very common and commonest operation next to cesarean section performed by both gynecologists and surgeons who more often do abdominal hysterectomy or a laparoscopy hysterectomy. And around 600,000 hysterectomies are done in USA per year, and in United Kingdom around 30.4 of 10,000 women in UK undergo hysterectomy. By the year 60, one of every 3 women have been deprived of uterus by hysterectomy. And Indian statistics says that 12 to 30 per 1,000 cases are performed in a country like this. Well, we have a vast population of 145 crores. So the magnitude of surgery being done in our country must be very, very, very high. And what do you mean by non-descent vaginal hysterectomy? It's a surgical removal of a non-prolapsed uterus via naturalis. So is vaginal hysterectomy difficult? So yes, people say that it is difficult because you are operating in a deep and narrow space. There is poor visibility of the operating field, almost a blind procedure which I do not agree to. Difficulty in putting the clamps and the stitches and cot and no place for the assistants to put their head inside to see. It becomes difficult. So let's think of an easy one. So if the uterus size is 8 to 10 weeks, is a multiparous woman, capacious vaginal canal, no previous cesarean section or an abdominal surgery, thinking of any adhesion or scar over there, adequate exposure, good light source, good assistance and good instruments like clamp and cautery, NDVH becomes an easy one. So before any surgery, vaginal hysterectomy also needs planning. There must be a preoperative feasibility and assessment. There must be a genuinity of the indication. It's not that everybody and anybody after age of 50 or 60 postmenopausal women for 1 to 2 bouts of bleeding or for 2 to 3 months, you should remove the uterus. There must be a symptomatology and you assess them clinically. Yes, that is a great role of sonography because sonography will help you in assessing the size of the uterus, the size of the myomyopathy present, adhesion and things which is very, very essential. There is a need of laparoscopy in certain cases, particularly in deep-seated endometriosis, but grade 3 and grade 4 endometriosis, laparoscopy is an aid. And anesthesia and OT setup and a good assistant is of much help. Do not forget the importance of examination of under anesthesia, particularly in obese women where you are not able to do a pelvic examination to ascertain the size of the uterus and adnexa. You can put the patient under anesthesia before your surgery, do a pelvic examination. The abdomen is lax, so examination will reveal you the size of the uterus and the adnexa. So skill development is one which is very essential. For any surgical procedure, we need techniques. And the techniques which we offer in vaginal hysterectomy is a good hemostasis. See, oxygen support to the anesthetist and hemostasis to the surgeon are the two key issues for a good surgery. The steps must be simple and you should do surgery in such a state that you avoid complication rather to make a complication and manage it. So reconsidering the problem and rational management, identifying the surgical limit and patient safety. See, you should be able to do what is the safety zone for the patient by a surgeon like you. And it is not that anybody should try for any size of the uterus. I will come to that later. But if you light in the radar in the step, more by more, you will be able to do in vaginal surgery. Well, for hemostasis, definitely you need hemostatic agent. But most important is the entering into the proper tissue plane or line of cleavage. If you are in the proper fascial layer, the vaginal mucosa peels up like the coconut and that there will be least bleeding. Of course, electrosurgical devices like coagulation and cauterization will help you to reduce the bleeding. The steps of hysterectomy, vaginal hysterectomy are simple. Access the anterior pouch, access the posterior pouch, open the anterior pouch or open the posterior pouch. If pouches are not opening from the beginning, don't bother. Go ahead with this surgery and put your clamp very close to the uterus and parallel to the uterus rather on the uterus so that you avoid complication of injuring other structure other than the uterine vessel and adnexa. So the concept of suture or sutureless, because we are propagating the message of sutureless hysterectomy. So the advantages which I will be able to tell you subsequently. So whether you do sutureless or suture or with clamp or clampless, that's different. But the technique are same. Ligate the pedicle securely so that there is no bleeding, no oozing from the pedicles, and you are avoiding injuring the other structure like the bladder, rectum, and the ureters. Debulking procedure is particularly helpful. I'll come to that because when the size of the uterus is big or the uterus has become, you have to reduce the size by coring or cutting in the midline or a hemisection or removing the myoma in one after another. And during the entire procedure, please maintain adequate tissue respect. A surgery deserves good tissue respect. Do the surgery cleanly and nicely and do not mess it up. And Finally, again, a word of caution regarding hemostasis. So, if you adopt a good technique, you will be able to perform your surgery with ease and you will face little complication. The number one technique which I am telling, the debulking and coring, particularly the size of the uterus is big. So what you do after you are ligating the Mackender's ligament, the uterosacral ligament, the uterine vessels, the bleeding is absolute minimum after that. You can do a hemisection, take a longitudinal incision on the body of the uterus from above downwards up to the cervix, cut open into two halves. Then you do a elliptical incision on your knife and remove the uterus in piecemeal, in slice one after another. So the size of the uterus will shrink, come to this center, and it is easy for you to clamp and coagulate or whatever you are using. Second thing is finding the lateral windows. It is explained by Dr. Siris said that in a case of previous cesarean section, if you are trying to open the anterior pouch, the bladder remains adherent to the anterior wall of the uterus in the midline, but it is loose. The peritoneum is loose on the lateral, both sides laterally. That is what they called as lateral windows. So if you come from both the lateral side, you can push up. The peritoneum is loose. If you come to the center, you can see that the adherent tissue, bladder is adherent to the uterus. Try to cut upper. Do not try to push with a gauze so that bladder will be averse. So cut on the uterine surface. So the uterus will be, some amount of uterine tissue may go with the bladder, but you will be able to push the bladder up by fine scissor dissection, not by blunt gauge dissection. Well, last one on the list, vessel sealing device are of a great help. Vessel sealing device are nothing but a extended version of electrosurgical device, so that they have a wide range of wattage. And with a vessel sealing device, you will be able to seal a vessel up to 7 millimeter diameter. Uterine vessel, being a vessel artery of 5 millimeter diameter, is effectively shielded. The collagen present in the vessel wall of the artery and the vein are fused, so it is automatically plugged and there is least bleeding there. That is the advantage of a vessel sealing device. If you adopt this technique, your surgery becomes easy. So what we are thinking as difficult or contraindicated for vaginal hysterectomy yesterday have become one indication today, and we say that there are difficult vaginal surgery. Well, the broadening horizon, you are able to do the surgery in the big uterus. And it was thought, how big is big? I'll come to that later again. Removal of the adnexa, it is so that the removal of the tubes and ovary are difficult from the vaginal side. So it is always easy for abdominal hysterectomy, laparoscopy hysterectomy to do. No. Removal of adhesions, particularly large myomas, you can get the line of cleavage, previous cesarean section, multiple abdominal scar, pelvic endometriosis, and nulliparity are one of the contraindication earlier. Even oncology, oncosurgery are also thought in contraindication for vaginal hysterectomy. So vessel sealing device, I'll like to say a few words. It is a wide range of patterns. It is not very updated version of a electrosurgical device or a cautery. It has got a wide range of wattage for 50 to 150 watt. It has got two monopolar, two bipolar. It has also underwater cautery. And the vessel sealing bipolar is that it can effectively seal a vessel up to 7 millimeter diameter. It is auto stop, means if the tissue held between the tip of the clamp, which the current passes from one tip to other, the tissue in between is coagulated, desiccated, and if it is properly cooked, the tissue is done, then the current will stop automatically. That is called auto stop, and it cuts automatically. And that if you press the pedal even after that, it will give a beep and there will be no further flow of current. So that's the advantage of this. You have 3 foot pedals. This is the one which I use, Martin Maxim. We have so many other electrosurgical device. You can program it. It has got coagulation, cutting as well, so that you can do away with this. So there are a number of things are available in the market today. So it is the one which you are comfortable with, you will be able to perform. So you choose your own electrosurgical device or equipment and you go ahead with the surgery and you are comfortable, whether it is a RB or Thunderwit um, um, or Matin or Alan or Salya, whatever, the market is full with German made, Indian made company, they're equally good. So the so-called barriers of vaginal hysterectomy, scar, size or skill, so should be avoided. And the descent of the uterus, the access of the pouches and the size of the uterus and the adhesion, these are the mental blocks for a gynecology. This should be removed from your mind with conviction, inclination, and preservation and indulgence. You will be able to do vaginal hysterectomy very easily. So let's go one after another. So large uterus. Let's say, ask us ourselves, how big is big? So the thing is that whether it will be able to do 14 weeks, 16 weeks, 18 weeks, 20 weeks, or more than that. It's not the size which is important. It's the one which we are able to do it confidently. We can do up to 20 big size. But please remember that to do it at is vaginally at any cost, you should not meddle with it too much. If it is taking a long time with a lot of bleeding, you are removing, you are coring, uterus is not coming. Let us identify my limit. Let's see that I am comfortable with 14 to 16 week size. I'll do it. And it's not a must that nobody will fail you if you are not able to remove something. So if the patient safety is important, you should also know your surgical limit. So one thing I must tell, that if a uterus is elongated vertically is easier to remove vaginally rather than the uterus is broad laterally. Because if it is broad, it is difficult to core or coagulate and it becomes easier one. So that's the one. Fibroid in the uterus, I told that ultrasound mapping is very, very essential, and that if you do a preoperative ultrasound assessment, the position of the fibroid will be able to, whether it is in the body, whether it is in the fundus, whether it is in the cervix, and then you will be able to know, so that you will be able to approach by doing a myomectomy. So it is posterior or anterior, it will be easy to know. In such a case, you go ahead, up, ligate the McIntyre's ligament, uterosacral ligament, uterine pedicles, then go up. Once the uterine has coagulated both the sides, you cut upon the myoma and rather overcut on it. The myoma will pop up and you put a myoma screw and remove it, and it will be pulled with a myoma screw. You get the pseudo capsule stretched and use your seizure
Sorry to
as a
interrupt you, sir. Your time is up.
Okay, previous cesarean section I have already told that you should approach through lateral windows. Don't struggle to push. Adenexa, it is able to remove it because you cut upon the round ligament, then you give a right angle clamp or Dr. Said's clamp, and it will very easily come out. So previous surgery is not a bar. The scar may be looking ghastly. You expect some amount of adhesion of momentum or gut. Please stay close to the uterus. Pelvic endometriosis is really a tenure of surgery because you may take laparoscopic assistance, particularly stage 3 and stage 4 endometriosis. And nulliparity, the introitus is tight, the vaginal space is narrow. In such a case, vessel sealing device or a coagulation and cutting, rather putting a clamp, cutting it and stitching with it, it will be difficult. I'll avoid the video because of constraint of time, but I want to conclude that vaginal hysterectomy is a preferred removal today. Vessel sealing device is a great boon, helps in difficult situations like lack of space in the lateral vaginal area or in large uteri. The technique of autostop, autocut, and vessel sealing make this surgery really is. Avoid thermal injury at any cost. No injury to the bladder or the ureter. And surgical comfort is more important to the surgeon rather having a dogma or a ego of removing everything vaginally. Training experience and expertise matter. Size of the uterus is immaterial if you can do it, and great vessel sealing device is a great boon. Laparoscopic assistance should be taken wherever necessary. Correct decision for surgery is mandatory. So that you can decide that I will do this case vaginally, I'll do this case laparoscopically, I'll do this case for by abdominal if it has still a place. So my guru says that if a 3.5 kg baby can be delivered vaginally, why can't you remove a 36 size of the uterus, remove similarly? Well, sky is the limit. Let's see how you do it, how you go ahead. We have beautiful marcelator is available. Things are available. The coagulation is very easy. It's put on the uterus. It melts like ice and you can remove it vaginally. Let's see what is there in future tomorrow. Thank you very much for a patient hearing. And because of lack of the time, I have many videos. I will share it subsequently in some other session. Thank you very much, chairpersons.
Thank you. Thank you so
sir.
much.
Thank you.
Hara
Sir,
sir, it was
there is
like
a request for link, na, Komal?
videos.
Yeah.
I will
link
share
lot
the
of
video
requests
link.
for videos. It was really
Yes, madam.
practical and very, very practical and so much take-home messages and tips and tricks you have shared. Thank you so
very
much.
nice. It was
And please
very
share the
nice.
videos also, sir.
Correct. And it's for the beginners especially, it was very good. The high encouragement to start doing vaginal if they are not doing. So at least let them start with the normal size uterus first and then they can proceed. So the trick is always in start doing the easy cases. Never do TLH for cases which are normal size, no adhesions. They should take it up vaginally. Yeah, thank you, Hara sir. That was wonderful.
Thank you very much.
Next. Yeah, please take it. Yeah. So, shall I introduce Komal? Kya karna?
Yes. Go ahead, please.
Yeah. So next, I think we have Dr. Tulisa Basnet, MD OBG, FIU GA Fellowship in Urogynec, and Associate Professor, Department of OBG, BP Koirala Institute of Health Sciences, Dharan, Nepal. So we have an international surgeon for you to present. So welcome you, Dr. Tulisa, and please start your presentation. Yeah, please do. Please share your slides.
Okay, thank you, ma'am, and thank you, respected chairpersons. Should I share my screen?
Yes,
please do.
Okay, is it visible?
Yeah, visible. Yeah.
Make it slideshow. Make it
So
full screen.
Is it in slideshow now?
No, it's not yet.
Not yet.
So maybe it is not. So maybe the Dr. Shreya should share it from her.
Yes, ma'am.
No, आपने किया है slideshow? आपने किया है?
I have done, but it is not coming in slideshow. That means some
It will
problem.
take some time. There will be a little lag period. So you can start presenting. Eventually, it will come.
Okay.
So that is easier for you, isn't it? So you start in between, because it is a nice. You may want the control. Otherwise, you keep on telling next, and that's a hassle. No, you start. Let us see. After some time, it may.
Okay, I'll just try once.
It's internet delay. That's all. You're presenting from Kathmandu.
No, I am from Dharan, ma'am. It is actually the eastern part of Nepal.
Okay. हाँ. अभी करना तो ये थोड़ा सा इधर में वो साइज थोड़ा सा बड़ा कर लीजिए अपना स्लाइड का. स्लाइड साइज को थोड़ा बड़ा करिए. Yeah, that one. Don't go too much. It will go out of sight. उतना करो. हाँ, काफी है. चलो, start please. Yeah. Bring it up. Yeah.
Okay. So the topic
is this a PDF format? ये PDF है क्या?
No, ma'am.
Okay, fine then. Okay. Because it is on the
slideshow mode, ma'am.
It's in the slideshow in my computer.
नहीं, एक बार और नहीं, आप full screen मोड में जाइए, hourglass में press करिए. Press on the hourglass icon.
I have done that.
No, once more. Yeah.
Do since beginning. You do slideshow since beginning. You click on the slideshow and then start since beginning.
It's in the slideshow mode only.
You click on PowerPoint presentation twice, then you do slideshow and then you start. After clicking slideshow, you do from beginning.
वैसे दिख रहा था ना कविता, उनका दिख रहा था.
दिख रहा था.
क्लियर अच्छा से दिख रहा था. Let her start, I feel. Let us start.
Shreya can do now.
Can we take the next talk?
No, don't
If there
do
is
that.
any technical issue, we can go ahead with the next talk.
1 minute. Let her share.
Okay,
She may
okay.
find it difficult. कर लेने दो, कर लेने दो. करो.
Okay, so the topic given to me today is urogenital fistula assessment in low research setup.
No, share your presentation.
No, it is not coming, and so that's why I asked.
Now it has come. It has come. अभी आया था.
मैम मैंने शेयर किया है. Can I
Shreya will share for her.
Yeah, okay, fine. Okay, fine. ICOG office, please do the honors. Yes.
Yes, ma'am.
So I will
Please
stop
do it.
you.
हाँ बिल्कुल. थोड़ा सा वो लोग share कर लेंगे.
Yeah, ma'am. That's why I have mailed the
आप शुरू करो. To go to the first slide. Nilima, go to the first slide, beta.
This is the first slide. It's in the.
हाँ, बढ़िया. चलो, great.
Next one, please. So, the previous speaker, Dr. Meena, in the previous session also discussed about the disease burden regarding obstetric fistula. So, it is said that more than 2 million young women in the South Asia and Sub-Saharan Africa are living with obstetric fistula. And worldwide, there are around 50,000 to 100,000 new cases annually. One interesting thing is that we can, since obstetric fistula is hidden in the community, what we can do is we can project the incidence from. We can project the incidence from the maternal mortality ratio, which is easily calculated, and so for each maternal mortality ratio there is one fistula case. So in that way their prevalence was calculated for Nepal, and in the similar way that can be calculated for India also. Next slide, please. So we already know that what is urogenital fistula, but in the year 2020 ICS has coined the term called pelvic floor fistula, which is the fistula affecting upper and lower genital tract, including uterus, cervix, vagina, and or different vaginal compartments and the neighboring organs like upper and lower urinary tract as well as lower bowel. Next, please. So while naming the fistula, we should always take in mind that the urinary component has to come before the genital component. Like if the communication is between bladder and vagina, so the bladder should come first. That how vesicovaginal is termed, and like that way we can name other fistulas depending on the communication. So the commonly used term for describing vesicovaginal fistula are depending upon the length from the urethral meatus as well as from the length of the cervix. It can be urethrovaginal, which is lying on within 3.5 centimeter from the urethral meatus. Juxtaurethral is at the level of uretrovesical junction, and that is the most common site. Mid-vaginal around 4 centimeter or more from the external urethral meatus. Juxtacervical is adjacent to the cervix, and that is commonly associated with post-cesarean section. Intracervical is between the bladder and the cervical canal. Again, that is associated with cesarean section. Another is circumferential fistula, where a part of the bladder has been separate from the part of urethra. So there is a discontinuity in the urinary tract, and while we are examining, we can feel the back of pubic bone easily through the vagina at the site of the gap. And another is ureterovaginal, where one or both ureter open into the genital tract, and it is usually iatrogenic after cesarean section or hysterectomy. And the next is vault fistula, that is at the vault. Next, please. So this is the same thing. I have kept in picture the different levels of vesicovaginal fistula and different types of vesicovaginal fistula. Next, please. So causes, as we already discussed, in developing countries, around 90 to 95% of the female genital fistulas are obstetric. While in developed countries, around 90% female genital fistulas are due to iatrogenic conditions. Next slide, please. Even though we say that around 90% of the fistula cases are due to obstetric condition, this is a 5-year retrospective data of VPKHS, where we can see that around both entity contribute around 50% in each. So the incidence of iatrogenic fistula is increasing. Next one. So coming to assessment, the diagnosis of the fistula is based on careful history, examination, and investigation with some diagnostic tests. Next one. So symptoms, we all know that the symptom of fistula is continuous involuntary leakage of urine. So that is usually associated with some recent major event in the life. That event can be childbirth in obstetric cases or pelvic surgery in iatrogenic cases. And if it is obstetric, then we have history of prolonged labor, delivery of stillborn baby, history of emergency cesarean section for obstetric labor or ruptured uterus or difficult instrumental delivery, and the patient starts leaking within days to weeks after childbirth or surgery. Next one. So in history taking, like I said that the symptom can be the patient is leaking all the time. So she is wet all the time. There are few exceptions. One of them is a very small fistula. It is very small fistula and placed in a high above. Then patient may have normal voiding in between and she might leak once the bladder starts filling completely, or she can leak while she coughs or some strenuous activities are done, and that can be confused with stress urinary incontinence. So while in history we have to ask about the duration, age of the patient, parity, because sometimes if it is a nulliparous or woman, then we have to take care of the future fertility after repair of the fistula, mode of delivery, and how long she was in labor. In that way we can know about how much the tissue destruction has occurred, where did the delivery take place, whether the child survived or not, and recent history of surgery or trauma, history of prolonged catheterization after that surgery. Indication of surgery is important because in difficult surgery where we try to go for hemostasis or adhesiolysis, in that case there is more chance of having urinary tract injuries, and that can lead to the fistula. Interval between no So interval between previous event and the urinary leakage. Usually fistula may present from the first day to 21st day post-operatively, but the mean duration or common duration is around 7 to 10 days post-op. Other neurological symptom, menstruation history, and whether previous repair has been done or not, that is very important because that might convert a simple fistula into complex fistula. Past medical or surgical history and social history is very important because once we repair the fistula, we have to rehabilitate patient to the society. So social history is also very important. Next slide, please. So while talking about fistula, the other components of obstructed labor injury complex has also to be dealt, and this has already been discussed by the previous speaker in previous session. So I'm skipping this. Next one. So in examination, while examining the fistula patient, it is very important to examine our nutritional status, especially anemia, dehydration, and malnutrition. If the patient is anemic or malnourished, then the chances of rate of success is very low. So we have to take care of those things at first. So she has to be nutritionally built up before going for surgery. Or mental status, if the patient is having low mood or she is in depression, that is again eventually going to affect her success rate. So that is also very important. So in neurological examination, usually that if there is association with obstructed labor, we might have some neurological problem in the lower limb, usually foot drop and low sensation of the lower limb can be there. So that has to be evaluated and that has to be taken care of. And abdominal examination, any mass or scars, that has to be seen. Next one, please. In local examination, while examining fistula, the most important thing is the good light source, adequate exposure, and the position. Usually we examine the fistula patient in lithotomy position, but sometime while doing so, we might miss the very distal fistula that are located in the uretrovesical junction or in the urethra. In that condition, the Sims position or Tenelenburg position may be helpful. So while doing local examination, we have to see for the perineal skin whether there are any urine dermatitis or not. Sometimes stones can be seen, or with the vulva moist and urine dipping to the vagina, that is easier for diagnosis. Whether associated perineal tears are there or not, if the urethral orifice can be seen or not. We can see in the third picture here that the urethral orifice, whole of the urethra is damaged and the bladder mucosa is being prolapsed. Next one, please. So in post-speculum examination, we can see the defect in the anterior wall, and whilst we see the defect, we have to find out the number, size, whether location, where is the location from external urethral meatus or cervix, status of the surrounding mucosa, whether there is fibrosis or inflammation or atrophy, vaginal stenosis is there or not, whether cervix can be visualized or not, if it is visualized, whether cervix is complete or not, whether it is torn or not, that we have to see, and whether it is associated with concomitant RBF or not. If it is associated with RBF, we have to take care of that first before going to fistula, urinary fistula, because if we leave RBF as it is and repair urinary fistula, then there might be chance of failure because of the contamination from stool. On palpation, we have to see for the depth of the vagina and presence of cervix, any defect and scarring. And if leaking is not seen, as it can be in the very small fistula, we can ask the patient to cough and see whether the jet of the urine is coming through the small defect or not. Next one, please. So these are some pictures. Here we can see that once we find out the defect, if we can pass a simple metal catheter through the urethra and see whether that is coming out through the defect or not. So in that way, it can confirm that this is the fistula. If that is not possible, like in second picture, we can put a metal catheter from the urethra and we can put a probe from the fistula. So in that way, if the two instruments meet, then of course that the defect is in the bladder. In the third also, we can see that the probe is coming out through the fistula in the vagina, and the bladder tissue being prolapsed also is seen in the speculum. And if you cannot, next, previous one please. So while doing so, if you cannot pass through the probe or metal catheter, then we have to suspect urethral stricture or circumferential fistula causing stricture at the proximal end of the urethra. So once we have examined, if the defect is easily seen, then that is fine, that we can diagnose VBF. But if the defect is not seen, then the role of dye test comes, where the dye used is dilute methylene blue. I think most of us know how to do dye test, so maybe I should skip this slide. Next one, please. So dye test can be negative in some fistula, like very small VBF or ureteric fistula. So what to do if dye test is negative? Then there comes the role of swab test. So we can put 2 to 3 dry swabs in the vagina and put a dye in the bladder. And once the foley is removed, and we can ask patient to walk around for around 30 minutes. Then will remove the swab. If the swab are stained with a blue dye, then it suggests the it suggests the vesicovaginal fistula. If the swabs are wet but it is not stained with the dye, then it might suggest the ureteric fistula or ectopic ureter. And if only the outer one swab is stained, then that might be because of stress incontinence. We can also do double dye test, in which phenazopyridine or pyridium can be given orally 2 to 3 hours before the examination, and we can put a dye in the bladder. And like previously, we can see put a swab in the vagina. If the swab is stained with orange color urine, then that might be ureteric. That is ureteric. If it is stained with a blue color dye, then that is vesicovaginal. And if it is not stained, then it is not a fistula. So if positive pyridium test with negative methylene blue test is suggestive of ureteric fistula. Next one, please. So while we are examining, we should also look for the length of the bladder and urethral length. So length of the bladder can be used, measured easily with help of uterine sound, and urethral length we can measure from the Foley catheter. We have to insert the Foley in the bladder and inflate the bladder, and we have to pull the Foley catheter so that the bulb of the Foley catheter reaches at the uretrovesical junction, and we can mark the outer urethral meatus, and then we will remove the Foley after deflating the balloon. And again, in outside, we can inflate the balloon and see the lower end of the balloon to the marking area. That will be the length of the urethra, because it is very important for success of fistula repair. So urethral length should be measured. And also we have to check for the levator muscle strength, because post fistula repair urinary incontinence is common. So if we check for levator muscle strength, and if it is weak, we have to train them for pelvic floor exercises, and that will help in managing the post fistula repair incontinence in future. Next slide, please. So this is the summary of what I have discussed till now, the flow chart showing how to do examination. Next one, please. So again, this is the flow chart. We have to take a history whether she leaks day or night, and if it does day and night is leaking, then fistula is unlikely. We have to think of other causes of urinary incontinence. Then examination, as I had discussed in detail earlier. So after dye test, if the Foley fails to pass, then we have to think of stricture or stone. And if the fistula is not there, and if we pass Foley, then there is no urine in the bladder. We have to do the dye test and look for whether dye test is positive or not. And when we pass the Foley and we can find that there is large amount of residual urine, then the continuous leaking may be because of overflow incontinence. We have to think of that also, because overflow incontinence, very severe interstitial incontinence, or severe urgency incontinence can present as a continuous leaking. Next one, please. Okay, time is up, so I think I should move to the. So this is how we will document the examination finding. This is the template for descriptive templates for documenting the finding. Next one, please. So investigations, very basic investigations like complete blood count, blood sugar and serology, and renal function test if renal impairment is suspected. And there is no role of doing urine analysis or culture because the urine is always contaminated. I think I should go to the last slide. So this classification system already discussed. So last slide. So these are the factors. They can be summarized at 12S, like site, size, scarring, previous surgery, shortness of stenosis of urethra, any concomitant RBF like stool, skill of the treating surgeon, serology status, sugar or diabetes, any chronic illness, sepsis and schistosomiasis. The gist of this presentation is we have to find out these factors while doing history and examination for a fistula patient. And these are few references. You can go through these books for better understanding of fistula examination and fistula surgery. Thank you.
Thank you, Dr. Basnet, for your lucid presentation. Chairpersons can go for the next talk by Dr. Dheera Samudria. So Dr. Dheera has MS and Fellowship Urogynecology, Consultant Gynecology, Jaslok Hospital and Bhatia Hospital, Mumbai. And her keen interest in to develop dedicated team in urogynecology. So we
चलो अभी
welcome
लगता है
you.
15 मिनट और लगेंगे तो चलो.
Yes, should I share my screen, ma'am?
Yes,
Yeah, sure.
Yeah. Yes.
Is my screen shared?
Yeah. Make it full screen.
Yes. Good evening, everyone. Thank you so much. I want to thank you, Team ICOG and Team Foxy, for giving me this opportunity. We already had two wonderful sessions by Dr. Meena and Dr. Tulsa now, who definitely touched upon the topics of urogenital fistula. They've actually set a platform for me, and they've made it so much easier for me. So thank you so much. Without further ado, going ahead, as we know, as discussed earlier, obstetric fistulas are more common in developing countries, whereas in developed countries, the gynecological fistulas are more common. I'll move ahead. The most modes of injury that can cause a bladder injury or vesicovaginal fistula would be one, either a direct injury to the urinary tract by either a cut or an incision, devascularization, where there can be an ischemic injury, a blunt dissection of the bladder, either in an open surgery or even in a laparoscopic surgery, The added patient risk factors which can lead to increased risk of a VVF are previous pelvic surgeries, any PID, previous pelvic radiation, endometriosis, BMI more than 35, diabetes, infection, any prior infection, and tobacco use. The most common presentation, I think I'll move ahead because this was very well dealt with by Dr. Tulsa. As Dr. Tulsa did mention, with the diagnosis, the most common what we would do is one is local examination, see the pooling of urine in the vagina or the vault, and then very often we ask the patient to take 2 tablets of pyridium and then see them again after 2 hours, and then check again, do a per speculum examination, and we know if the urine, if the fluid is orange in color, we know it's definitely urine. And very often we do a CT urogram to know the exact number, the site, the size of the fistula, and to also rule out any ureteric fistulas. Coming to the management, which is my topic, abdominal versus vaginal repair. The timing of the repair, back in the day, depends on earlier they would say we should wait for 3 to 6 months, but actually it really depends on the condition and quality of the tissue. If the tissue is pliable, it shouldn't be inflamed. It should be epithelialized, free of any granulation tissue, and there should not be any necrosis. It would also depend on the surgeon experience. However, the patients who are awaiting surgery should be given a good perineal care and urinary care instructions in terms of frequent pad changes and frequent voiding to avoid any continuous soiling of their clothing. Prolonged Foley's catheterization, if someone is on with the thigh bag, it should be removed 2 weeks before the surgery. Any dermatitis that has occurred because of continuous urinary leakage care should be treated with either sitz bath or zinc oxide barrier creams. Postmenopausal women can be given vaginal estrogen to improve their urogenital health. And correct malnutrition, give a high protein diet, correct the anemia, because this would help in better healing of the tissue, which is very essential for VVF healing. Coming to the general principles, be it the abdominal route or the vaginal route, the general principle of surgical repair remain the same. That is adequate exposure and mobilization, approximation of healthy tissue layers. The closure should be watertight, and the sutures, the sutures taken for the vagina, taken for the bladder, should be tension-free. And this tension-free sutures can only happen if there's been adequate exposure and mobilization. If needed, an interposition of a vascularized tissue graft can be kept, and there should be adequate bladder drainage post the surgical repair. The 2 routes of repair can be either vaginal or abdominal, and abdominal can be either open, laparoscopic, or robotic assisted based on the surgeon experience. Majority of the VVFs can be safely repaired vaginally, especially if they are due to gynecological injury. The advantages of a vaginal repair are decreased operative time, less blood loss, less post-operative pain, and shorter hospital stay. In the abdominal route, where the fistulas which are not amenable vaginally should be tackled abdominally. And what fistulas are those? They would be large fistulas, high or retracted fistulas, restricted vaginal access due to scarring of the vagina or stenosis of the vagina, a very long vagina. Again, it would be hard to access the fistula, and multiple fistulae, better to be repaired abdominally. Or if there's any involvement of the uterus, the cervix, or the bowel, if there's any need for a ureteric implantation, and depending on the surgeon's expertise. Always remember, before going in for a VVF repair, it's always prudent to do a cystoscopy, and if the fistula is close to the ureteric orifices, it's always better to put in a stent, stents to in order to identify and delineate the ureteric openings and to avoid any injury. Okay. The general principles remain the same. The principles are dissect the vagina, dissect the bladder, dissect the fistulous tract, excise the edges of the fistula, and then reapproximate the vaginal, close the vaginal end, close the bladder, and if possible, between them. So in the vaginal route, which is most commonly called as the Latsko repair, you can see first stay sutures are being applied. And after the circumferential incision which is given, the fistulous tract is excised, the vaginal mucosa is widely mobilized and closed, and then the bladder is closed. And as I think shown earlier as well by Dr. Meena ma'am, to place in the vaginal route, the most common graft which is placed is the Martius flap, which is basically the fat of the labia majora, which is tunneled and brought in between the bladder and the vagina. This would be a video of a vaginal repair of a VVF. This was done by Dr. Pranay Shah, and I was a part of the surgical team. I'll just play the video. In this, we can see there's a guide wire that goes through the urethra and coming out of the fistulous tract. A dilator is inserted to dilate the fistulous tract so that we can then insert the Foley's catheter and inflate the bulb. Here we've dilated the fistulous tract. The Foley's catheter is inserted through the tract and inflated, and this will give us traction on the fistula. Stay sutures are applied around the fistula. The fistulous tract is excised so that there's healthy tissue. After the fistulous tract is excised, the bladder is closed in 2 layers here. Using 2-0 vicryl, even 3-0 vicryl can be used. This is the second layer of the bladder suturing. And then the vagina is closed with interrupted sutures. Here we did not, after that, the watertight closure was confirmed by inserting betadine solution, and there was no leak seen. Here we did not need to place a flap because it was a single fistula, was not a recurring fistula. It wasn't due to radiation. So the need for an interpositioned flap was not required. Moving ahead, the abdominal repair, again, the principles would be the same: excision of the fistulous tract, vagina and bladder mobilization. And over here, the flap which would be interposed most commonly is the omental flap, which can be brought down and kept between the bladder and the vagina. This is a case, again, of abdominal repair of a VVF. This was a case done by Dr. Diksha Pandey, and I was a part of the surgical team then. So here this is a CT fistulogram. We can see here we can see in the center the round is the Foley's bulb through which the positive contrast has been injected, and that's the bladder. Here we go ahead with a cystoscopy. You can see bilateral ureteric stents have been placed. The central catheter is going through and through the fistula. So we go ahead with the abdominal repair. The uterus is held with the uterus holding clamp. The bladder is dissected from the vagina. Sharp dissection is preferred. Here we see the stay sutures are applied on the bladder, and the what we are holding is the Foley's bulb because we will do a cystotomy. This is the abdominal repair is called the O'Connor's technique, where a cystotomy is made. Here an incision is made over the bladder, that is over the bulb, which helps in dilating it. Now we've entered the bladder, and once again stay sutures are applied so that we do not lose the edges of the bladder. Here the Foley's catheter is brought in. Our incision is extended cephalad so as to reach the fistula and separate the bladder completely from the vagina. As we said, mobilization is very essential for a good repair. Again, stay sutures are being applied. What we are seeing down is the fistula, the triangular opening. Here again, the bladder is fully separated. The central white, that's the fistula, which has been out delineated, that the bladder, the vagina is V. Here we are just marking the edges of the fistula with the electrocautery, which we would excise. The edges which excise are always sent for histopathology, very rarely to rule out any CA. But also the main aim of excising the edges would be for healthy tissue. Here the vagina, after excising the fistulous tract, the vagina is being approximated. What's important here, you're seeing the vagina is closed vertically and the bladder later would be closed horizontally. So the chances of recurrence are low. Here the Foley's catheter is again, it is inflated, which we had initially put in. Here as discussed, here we are placing the omental flap as the interposition graft. Just 2 sutures are placed so that it's in place. Here we put in a suprapubic cystotomy drain, SPC. This provides additional drainage in case there's any debris, any collection, and in case a per urethral catheter gets blocked, it's continuously draining through the SPC. Now you can see the bladder is being closed, and here it's being closed horizontally. So if our bladder and vaginal incisions are perpendicular to each other, as even mentioned by Dr. Meena ma'am, the chances of recurrence and failure are lower. Again, after the closure of the bladder, we check for a watertight closure. Here we've injected the methylene blue dye and no leak is seen. And hence, then we close the abdomen. Yeah. Post-operative management would include a course of antibiotics and continuous bladder drainage. It varies from 2 to 4 weeks. Sometimes if the SPC is there, what we do is we can remove the SPC after 2 weeks and then keep the per urethral catheter for another 2 weeks and then remove the per urethral catheter after 2 weeks. That way, even the SPC point heals and there remains continuous drainage of the bladder. We very often give them anticholinergics because after the VVF repair and especially even if they have the ureteric stents, there persist bladder spasms which can be treated with anticholinergics. Some people follow doing a cystogram after removal of the catheter to again confirm that that there's been no recurrence and it's healed well. How do we prevent? This has actually been dealt very well by Dr. Tanveer as well initially on tips and tricks in surgeries and how to prevent injuries, which he covered even in the bladder. So it would be Foley's catheterization, sharp dissection of the bladder of the uterus, cervix, vagina, careful vaginal cuff closure, retrograde bladder filling, and careful use of energy sources during dissection. There can be lateral spread, so we should watch for that, and bladder suturing only after mobilization of the injured area, where I think Dr. Tanvi did show us a lovely video where she identified the suture and even cut it. Thank you.
Yeah. Stop sharing. Yeah. Thank you very much. It was very nice, very, very illustrative. I think we have the next speaker waiting. Yeah, very nice. Yes, I agree with Mukta. It was very good. Yeah. Komal, you are there, Komal? Can you introduce Dr. Pankaj Sarawde? Hello? Am I audible?
Please yes, Shobha ma'am, you are audible. Please introduce Dr. Pankaj Sarawde.
Yeah, so it's a pleasure to introduce Dr. Pankaj V. Sarawde, consultant obstetrician gynecologist from Pune, Cradle Maternity and Women's Care, especially interested in vaginal perineal surgery and urogynecology. He is the chairperson of Vaginal Surgery Committee AMOX 24-26 and managing committee meeting of SOVC Maharashtra Chapter 25-26. He is also managing committee meeting of POGS 25-26, vice president of POGS in the past, general secretary also in the past. So we welcome you to give your talk, Dr. Pankaj. Waiting to hear.
Yeah. Thank you, madam. Good evening, all. At the outset, let me thank Dr. Parag Binwale sir for giving me an opportunity to share with you my views on this topic. Let me share my presentation. Yeah. Is it visible?
Yes, sir.
Yeah. Thank you.
Can do a slideshow.
Yeah. Okay.
Yeah,
so, yes. OSE, a short form for obstetric anal sphincter injuries, impacts women's life dreadfully. OSE affects women's life by causing anal incontinence, by causing urgency urination, by pain and sexual problems leading to dyspareunia. You can imagine the psychological and social impact. We have seen about the urinary incontinence in previous lecture, how it affects women's life psychologically as well as socially. So you can imagine how impact would be with the fecal incontinence in these patients. Pelvic floor problems, prolapses are all common postmenopausally in cases who had experienced OSE during labor, and a significant proportion have elective cesarean section for all their subsequent births, of course, because gynecologists and patients are equally dreaded of the same situation taking place again and again. Out of all these consequences, the anal incontinence is the most stressful and devastating condition About 10% of the women throughout their life would report anal incontinence, which is twice as common in women as compared to men. And it is very important to note at this point that about 50 to 70% of women who have had OSC during labor have anal incontinence sometime later in their life. 20% of women with urinary incontinence also have concomitant fecal incontinence as well. So the perineum is completely damaged, leading to urinary incontinence as well as fecal incontinence and all other problems on the spectrum from looseness of perineum, pain in the perineum, to the fecal incontinence would be experienced by many of these women. So such dreadful condition of OSC, can it be prevented? As obstetricians, can we do something to prevent this condition in women who are suffering it? So objective of today's talk is to define OSC, to discuss about its epidemiology and impact on the women's life, identify risk factors so that we can take extra precautions in patients who have risk factors, review prevention strategies, and to outline the postpartum care and training to help these women. So what is OSC? Laceration of perineum and perineal musculature which extends into the external sphincter ani at the time of vaginal delivery is known as OSC. So in short, OSC is equal to third and fourth degree perineal tears. According to the Abdul Sultan classification of OSC, which is accepted worldwide, third and fourth degree tears are tears where anal sphincters are involved. So third degree tears where external and or internal anal sphincter are involved. Depending upon that, it is graded as 3A, 3B, and 3C. And fourth degree tear where internal and external anal sphincter both are involved. At the same time, it extends into the anal mucosa as well. So this is a third degree perineal tear and fourth degree perineal tear, a diagrammatic representation of both of them, which is known as OSC by this definition. So epidemiology wise, about 2 to 6% of women who have had vaginal birth would experience this. It is higher with the instrumental deliveries, and it is still higher with the patients who have had instrumental deliveries without being episiotomies made. So consequences, as we have seen, are very devastating: anal incontinence, chronic pelvic pain, dyspareunia, and psychological distress. Let us try and find out what are the risk factors so that we can take extra precautions. The risk factors are maternal as well as fetal and intrapartum conditions. Now, maternal risk factors are either avoidable or unavoidable. Few of them are modifiable and many of them are not modifiable, like primiparity, advanced maternal age, short perineum, Asian ethnicity, and history of OS in the previous delivery are few factors which are non-modifiable factors. This chart shows all the risk factors for OSC, and on the right side there are relative risks associated with these risk factors. So I would like to highlight that the patients who have occipito-posterior position, patients who have midline episiotomy, and patients who have instrumental delivery have almost 3 times higher chance of encountering OSC as compared to other risk factors. So these are the most important major risk factors which one should pay attention to. There are other fetal and intrapartum risk factors like big baby, macrosomia, shoulder dystocia, occipito-posterior position, prolonged second phase of labor, instrumental deliveries, and midline episiotomy. Out of instrumental deliveries, forceps deliveries have more chance of OSCs as compared to the vacuum deliveries for obvious reasons. So can we prevent this condition? So there are two measures which we can take as obstetricians, and let us find out what are these measures. There are few measures which are antenatal measures. One can start taking precautions antenatally so that we can avoid encountering OSC intrapartum. So perineal massage after 34 weeks is one intervention which has been shown to give significant reduction in the number of OSC cases. The reduction in few studies has been to the extent of almost 50%. Optimize maternal nutrition and weight, because underweight patients and malnourished patients would have weak muscles and they have higher chance of OSC consequences. Manage diabetes to prevent macrosomia and shoulder dystocia, and educate women about the pelvic floor health. It is an important part of OSC prevention management that women are educated prenatally about the consequences of labor they would have to face later in life. So perineal massage is a method where patient is advised to massage this way by inserting two fingers inside the introitus, and she may use some lubrication also. Gently massage the perineum, lightly stretch it for 2 to 3 minutes every day. A patient or her partner can also do this, which has shown very positive results in preventing OSC. Intrapartum strategies are to use warm compresses during crowning, perineal support, controlled head delivery, and avoid routine midline episiotomy. The position in labor also has shown differences in the incidence of OSC. This chart depicts different positions and the incidence of OSC during those positions. Here it is important to note that lithotomy position, which is commonly uh, practiced in India, has about 3.53% chance of OSC as compared to that semi-reclined position at just 1.22 and the least chance of patients landing up with OSC. So all those who are using lithotomy position, it's time that we shift over to the semi-reclined position. And all those who are using semi-reclined or semi-sitting position should be happy that we are doing the best thing what we can do with the present knowledge available. Warm compresses would reduce OSCs in 50% of the cases, wherein a napkin is soaked in warm, lukewarm water at the time of crowning. It is pressed against the perineum, which is stretched, and the one precaution needs to be taken that the water has to be just lukewarm, otherwise patients would have scalding, especially for those patients who have epidural anesthesia, who the chances of scalding are more. So that has to be ensured by the care provider. Ridgen's maneuver, which is a commonly practiced maneuver while doing delivery, is important in preventing OSC, wherein the dominant hand pushes the chin upwards and facilitates delivery of chin by flexion of the extension of the head, while the non-dominant hand is supporting the occiput, maintaining maximum flexion so that the baby delivers with smallest diameter of the head, avoiding perineal tears. Hands-on perineal support has shown significant benefit in cases of avoiding OSCs. Hands-on support, there are two methods, Finnish method and Viennese method, which are depicted in this diagram. In both the methods, the extended fingers, index finger and the thumb finger, is kept across the introitus, and the palm or the folded other fingers are supporting the perineal body, protecting external anal sphincter. The difference in Finnish method and Viennese method is that in Finnish method, other three fingers are folded and pushed against the perineal body, while in cases of Viennese method, those fingers are extended and the thinner eminence of the palm is pressed against the body. So both the methods have equal results, and it's a choice of an obstetrician, whichever is comfortable. So how does perineal support work? That's the most important part of preventing OSC. So we need to know how does it work. It works by distributing highest perineal tension over the wider area. So vector distribution wise, the tension is divided and it doesn't act at a single point, leading to tearing later in life. Mainly reduces the transverse perineal tension by fingers along the lateral walls of introitus. It protects perineal body at the fetal head extension, which is a point which bears maximum brunt, delivering fetal head with least possible diameter as non-dominant hand keeps on pressing on the occiput, leading to increased flexion of the baby's head, and by allowing slow expulsion of the head. The head which comes out like a bullet definitely tears everything and comes out. So slow expulsion is important. It is also important that the accoucher should advise patient in labor not to push with contractions in second stage of labor. In fact, at the time of contraction, she should have shallow breaths rather than pushing and let the uterine contraction do its job, because uterine contraction pressure and the pressure given by mother at the same time would lead to more number of OSC. Where is the role of episiotomy in prevention of OSC? So episiotomy may not be used as a routine, but a judicious use is important. The pendulum has shifted from not giving episiotomies to giving episiotomy to every patient, but we need to be judicious in using episiotomy for protecting perineum. So mediolateral is safe. Chances of OIC are only 2.9% as compared to midline where chances are 12%. In primaries with mediolateral chances 6% and with midline it is 19%. So indications are instrumental delivery and fetal distress, definite indications. And there are other indications like thick perineum, short perineum body, where a person can decide to give an episiotomy to protect perineum. Proper angle is most important. 60 degrees from the midline at the crowning, because at the crowning you are making a cut not on a flat surface but on a spherical surface. So episiotomy made at 45-degree angle would move to 20 degrees closer to the anus. So it is important that we give episiotomy exactly at 60 degrees to the midline so that later on it becomes 45 degrees with the midline. And to facilitate this, there are few advances available which I'll be talking about later. These are EP scissors which are available, wherein this bar which is attached to the scissor is aligned to the midline so that the blades automatically make an angle of 60 degrees. So you can't miss taking an episiotomy at other angle. This is one perineal protection device which is used in few cases, wherein this serrated part is inserted between the head and the perineum at the second stage at the time of crowning, and the two flaps like butterfly wings are aligned along the lateral sides of the anus during second stage. So this device is in few cases has helped prevent OICs also. These are EPNO devices which can be used antenatally by patients. So she has to insert this balloon, blue and pink one, inside the vagina. This is a massaging device which can be used, and compress it so that it swells, stretches the perineum gently. So manual massage can be replaced by using this EPNO device by the patients, which would help practice perineal massage. These are perineal massage wands which are commercially available, which can be used along with lubrication for perineal massage. So risk factors for obstetric anal sphincter injuries at a tertiary care center in South India study conducted by Kameshwari madam says that episiotomy protected against sphincter injuries, particularly in instrumental deliveries and in cases of shoulder dystocia, to avoid major degree of loss. So all these things which we described are included into the RCOG OSC care bundle, which is being implemented by RCOG all over UK, which includes antenatal information to the patient, episiotomy when needed at 60 degrees, manual perineal protection, and perineum should be examined thoroughly post-delivery, including PR examination to assess occult obstetric injuries. So systematic examination under good lighting by trained person is necessary. Use of antibiotics and laxatives are important. So obstetric anal sphincter injuries during instrumental vaginal delivery. This is an observational study published recently in July 24 in BJOG says that episiotomy, especially mediolateral, are associated with 45% decreased risk of prevalence of OIC. So episiotomy do have a role when they are used judiciously. Follow-up by physiotherapy, follow-up clinic at 6 to 12 weeks. Once she delivers, patient do not really visit again to the obstetrician, but it is our duty to advise them to visit and guide them for physiotherapy, give them psychological support, whoever has OICs, and referral in cases of persistent symptoms to a trained person, as well as training our staff to identify and avoid OICs is the way to prevent OIC. So this antenatal, intrapartum and postpartum strategies to prevent OICs would help avoid suffering which our women are exposed to. In summary, OIC is preventable with proper strategies, and episiotomy should be used judiciously, and training and implementation of RCOG care bundle to reduce OICs rate is advised. Thank you very much for your patient hearing, and I'm sorry for overshooting the time.
Just stop sharing.
Stop sharing.
Stop sharing.
Hi.
Yeah, thank you. That was very crisp. Yes, Suman. Yes, Suman.
Yes. Pankaj, it was really a nice presentation.
Oh, thank you, ma'am.
You covered all the points so elaborately. So thank you very much. Since we are running short of time, so we'll not.
Yes, thank you very much. Thank you for the opportunity.
Thank you.
Thank you, chairpersons and the speakers. Now we move on to
Thank
the
you
third
very
session.
much.
And the chairperson for the said session are Dr. Achla Batra, Dr. Kiran Pandey, and Dr. JB Sharma. Can we have slides, please? Professor Achla Batra was National President NARCHI for 22-23. Madam has been an instrumental force and holding many important positions with many publications in textbook and journals. So, Madam, we welcome you for this session. Next chairperson is Dr. Kiran Pandey, ma'am. Dr. Kiran Pandey is professor and head of the department GSVN Medical College, Kanpur.
Thank you.
ICC Governing Council member 23 to 25. And Madam is a well-known obstetrician and a teacher, President UP chapter, and so many research and awards to Madam's credit. Madam, welcome. And
Thank
our
you.
chairperson is Dr. JB Sharma. Dr. JB Sharma.
Dr.
And
Fessy Lewis is the third.
Dr. Fessy Louis and Dr.
इसमें
Lewis is
बेटर
senior
मैं भी दिला
consultant and associate
5
professor
मिनट
in charge
मैं ड्रेसिंग करानी वहां पे सिस्टर को लिटाए
from Amrita Institute of Medical Sciences, Kochi, Kerala. Foxy Vice President 2021 and Vice President Kerala Chapter IAG. Sir, we welcome you for this session. And chairpersons, without further delay, please introduce our first speaker for the session, Dr. Uma Rani Swain.
Yeah, it's a great pleasure to introduce a queen of vaginal surgery from Delhi, Dr. Uma Rani Swain. She can do anything vaginally, and she has organized so many urogyne workshops and live surgeries, and we've seen her operate, and she's won the Best Research Paper Award in RCOG, and she's General Secretary of SOFSTI. And she's going to talk about a stitch in time, Shirodkar stitch. Over to you, Uma.
Good evening, madam. Good evening, the chairpersons. And thank
Hello,
you.
Dr. Uma.
Hi.
Nice seeing you. We missed you over at our IMS.
I know. Ma'am, now I am sharing my screen.
Yes.
Yes.
It's not getting shared. Can you see? No?
Yes, ma'am. Make it full screen, ma'am.
Okay, okay. That will. You can see the screen now?
Yes, ma'am. Yes, ma'am.
Okay,
Go
okay.
ahead.
Yeah. Yeah, the topic which is given to me is a modified Shirodkar cervical surplus, and I believe it is a very novel procedure for cervical incompetency. And to introduce the topic, the cervical surplus is a stitch, well-known surgical procedure carried out mostly during pregnancy to place a stitch around the cervix, aiming to give a mechanical support to maintain the cervical competency, thereby reducing the risk of second trimester abortion and preterm birth. There are two types of cervical surplus. One is prophylactic and a rescue. The prophylactic surgical procedure will be undertaken in 12 to 16 weeks of gestation or 2 to 3 weeks prior to the last abnormal or sad events. And the rescue operation is always done the time of imminent abortion or preterm contraction or dilated cervix. The cervical incompetence is it's a diagnosis by persistent opening of the internal os, that is you can see in the ultrasonographically, or clinically also you can diagnose by putting a Hagar number 6 to 8 and also the Follis catheter number 14 with a 2 to 3 centimeter dilated balloon which can go without any resistance, and usually there is a history of painless spontaneous dilatation of cervix expelling the product of conception, which is known as born of cow, and taken as a second trimester failure. So incident is very less, but nowadays because of the good number of IVF pregnancy, twins pregnancy, and the latest pregnancy, it is coming at very high volume. The clinically represent in the second trimester pregnancy failure or rupture of membrane with resultant oligohydramnios. The patient is high risk for preterm delivery. So these are the typical picture when we see the patient is expelling the fetus outside the vagina or inside the vagina, and she might expel the product of conception along with the placenta. So the reasons are many. I am not going to see all these things, but the diagnosis is usually clinical diagnosis by fetal fibronectin and cervical mucus before TBS examination. Ultrasonographically, early features of cervical incompetence are cervix opening at rest or with a fundal pressure. The bulging of the fetal membrane into the wide internal pores that may be T-shape, Y-shape, V-shape or U-shape. The complete bulging can seen as an hourglass appearance of the bulge membrane. The shortening of the cervical is around obvious to ultrasonography as well as the clinician. There are several cases of the cases we have seen. The bulging membrane contains the fetal parts, umbilical cord and everything. So these are the cervical incompetency features. You will see the U-shaped bulging. There's the external loss and this is the internal loss. And you have Y-shaped bulging. There may be B-shaped bulging. There is a U-shaped bulging. So the length of the cervix is usually normally more than equal to 3 centimeter. If it is less than 2.57, there is a warning symptoms that the patient might go for a imminent expulsion. So if it is happening in the before 24 weeks, then there is a alert and the red flag. The risk of preterm delivery, if the length is less than 2.5 centimeter, 18%, less than 20 millimeter, the 25%, less than 15 millimeter, 50%. So there is cervical furling, important finding is there, and more than 15% of furling before 25 weeks, then it associated 80% of the failure of pregnancy. The description may be, I'll come straight to the vaginal, the procedure, how it has been done, the vaginal or abdominal procedure, and the benefit of the procedure is to prolongation of the pregnancy. So there are the history induced. You can do a assessment yourself with the history given by the patient. That's a painless expulsion of the product of conception during second trimester phase of the patient. And second, that the preterm labor and the ultrasound indication also we have already discussed. And there may be rescue cerclage when the cervix is already open and the fetal membrane is exposed. So there are high risk patients. We discriminate to two types. One is high risk, one is intermediate risk. If the previous preterm birth or the second trimester loss is 16-34 weeks, then by high risk. Previous PROM and previous case of cerclage, known case of uterine variant, that is abnormal, that's some uterine anomaly, history of tracheotomy. If it is low risk or moderate risk, as the history of the previous, the women which include who have a history of the previous full dilatation, C-section, there may be, they are prone for cervical incompetence, and there may be cervical operation, excision of the more than 1 centimeter depth, so that we can encroaching upon the internal loss. So the type of cerclage you already know that the Sirotker operation, McDonald operation, and sealing operation. There are three types. Sirotker is Sirotker operation. We are just planning that the cervical, this is the cervical canal, and this is the abdominal procedure, which is transabdominal cerclage, and this is the McDonald operation, just proximal to the external loss. But what we do in a modified Sirotker operation, we want to, and we will reach at the level of isthmus. It's not the isthmus, but internal loss. This is our modified Sirotker operation. So with if you go abdominally, you see there is a band like structure in between the cervix and the uterus. Here we cannot able to know whether it is in the isthmus or in the internal loss. The timing of procedure we have already discussed, and the preconceptual cerclage is the preconceptual cerclage. That is means you are giving a cerclage operation in a non-pregnant, non-gravid uterus. That is indicate that is no less than the cerclage during pregnancy. So this should be considered when possible because of the reduced anesthesia risk and technical advantage of the operating uterus with a woman which is not pregnant. Furthermore, there is no evidence that the preconceptual transabdominal cerclage has any detrimental impact on the fertility or care and the treatment for the early miscarriage. So preoperative consideration is you should be 100% sure that you are operating upon a needy or indicated case. And then these are the cervical cerclage, and then the cerclage in the malform uterus also we have seen this bifid, bidelphys and bicollis. we can have a circulars. Here you have it is all happening under the Shirodkar operation. And you see, this is your reflecting the bladder, the vaginal flap away from the bladder. You can go up to the internal os, and as a clinician, you can able to feel the internal os posteriorly, anteriorly. So that is your target actually. Then you do a circulars on the internal os level and cover the blood again. This anterior vagina to the cervix. This is the circulars, which is actually at the level of internal os. But actually, what is the modification? What is the original Shirodkar is that the Shirodkar operation, we do not encroach upon the posterior aspect of the cervix, that is the posterior vaginal flap from the cervix. We only go anteriorly up to the internal os. That is the modification. And now I will show you the modified Shirodkar operation where we can go up to the internal os and how effective is that. Here, mind it, we are not using this ethibond, that is your Marcelin tape, but I am depending upon the number 1 proline suture. This is the operation goes like that. You just see, we usually toilet the vagina with saline, not in betadine, because we do not want to give any synthetic or in the chemical products inside the vagina or the cervix. So we wash with plenty of saline. Then you, with the infiltration of the vasopressin solution, we go on reflecting the anterior vaginal wall from that of the cervix and going inside and inside. Then with the fingertip, we can feel that the vagina, the bladder flap or the fascia is receding from that of the cervix, and you can feel the internal os level. Then you go to the posterior surface. Unlike typical Shirodkar, we are also going to reflect the posterior vaginal wall from that of the cervix. We just open it as we do in the NDBH or any vaginal hysterectomy. So just cut the posterior vaginal wall laterally and both laterally, and reflect the vaginal wall from that of the cervix. But here we do not go to inside the pouch of the glass. We stay away from the peritoneum to reduce the advantage of the not going to the intrapelvic cavity is many. Will be discussed later on. And then with the reflection, we just go posteriorly. With the number 1 proline thread, we are just piercing the needle from 5 o'clock position to the substance of the cervix in the left side. And now this suture is been passed from the posterior flap of the vagina. Then we go to the cervix. And then with the finger guidance, you just manipulate the needle to come out of the anterior aspect of the cervix at the level of internal os. And retrieve the needle, and then you give a small passage of the suture to at the 12 o'clock position of the cervix to make it more stabilized at that level, that is internal os. Again coming from 11 o'clock position to the 7 o'clock position under guard of your finger. And the whole aim is to go in the substance of the cervix, not around the cervix. Otherwise, the needle the suture will slip with 1 or 2 weeks of the procedure. Then again, there is a bite coming from the 6 o'clock position to make it stabilized. And because I am taking a number 1 proline, I feel I will go 1 round surrounding the first one, and I always aim at least half a centimeter to 1 centimeter proximal to the initial ligature. The same procedure been carried out to coming 1-2 round of sutures going and coming out of the vagina. Then this needle will come out of the vagina, so that we will go as deep as the pouch of the glass at the level of 2 uteruscular ligament in time. Gradually, you just have a tight knot and give 3, 4, 7, 8 knot, and keep the thread little bit bigger And then you close the flap of the vagina, which is detached from the cervix. And ultimately, we'll gain this. This is the anterior closure, and we have done the posterior closure. And then you come out the sponge holder, and this is the thread which is visible. Posterior closure can be completed. You can do on the catgut or your rapid vehicle. And this is the final result. The step I am not going to elaborate because my time is now up. And the advantage of high circulage is the vaginal approach. All risk of abdominal surgery can be avoided. Fulfill all the criteria of Shirodkar circulage. Maintains the maximum length of the cervix. Suitable to any suitable with any non-absorbable suture. No chance of uterine handling or unnecessary manipulation. No, we select number 1 Foley with 32 to 35 millimeter needle. Because of the slippery surface and less of incidents of infection, the suture remains buried inside the vagina, but except this knot which is outside. So as the knot remain outside, the suture removal, both elective and emergency is easy and maybe OPD procedure. And because my time is up, the critical steps are select non-observable sutures or needle suture over observable suture. Monofilament is better than braided. Suture placed at the level of internal os, not at the isthmus. Needle trajectory under guard of the finger with sustained gentle pressure, and the suture bites should include the outer 1/3 of the cervix for effective holding. The post-operative, we all know that tocolytic antibiotic progesterone supplementation, but here I emphasize that the rest is advisable, but no bed rest. The effective circulage allow the near normal post-operative life. So the complications are many, but when you are vaginally, you can tackle the situation very early because it is under your control. Thank you very much.
Dr. Uma very well illustrated procedure, and I agree with you. You know, using Proline is better than using Marceline tape because if you have to do vaginal delivery, the tape has to be removed, and Marceline becomes, it becomes fibrosed and difficult to remove. So I also prefer Marceline, and definitely infection is also less with the Marceline tape. And of course, if the stitch when you are taking from the sides, you can sometimes there's a modification in which they hold the lateral side of the vagina between the anterior and posterior incision with Ellis. So the passage of the needle becomes easier that way. But I think you didn't have the time to show the tips and tricks. You definitely, I know you do it. So thank you very much. And somebody has asked, what material you are using for McDonald's.
What?
McDonald's stitch.
Silk.
Yes. Actually, madam, we prefer number 2 Proline. Okay, but what I see in the RR hospital, only I have seen the number 2 Proline at RR hospital. I am not able to find it anywhere with Johnson & Johnson requesting. But I feel if I use number 1 Proline, so I go twice, 2 round of suture.
Yeah. Thank you, Uma.
Thank you, Dr. Uma. Very nice presentation.
Thank you. Thank you.
So I think let's invite the second speaker, Dr. Mohini Agrawal. Dr. Mohini is Director and Senior Consultant Urogynaecology, Pelvic Health Center, Bhatinda. And she has done DNB and she's Fellow of Urogynecology and Pelvic Reconstructive Surgery from AIMS, the most prestigious college. And her special interest, of course, urogynecology, but besides that, menopause and geriatric health and pelvic pain. And she has been member of fellow trainee and early cancer professional, commitment to IUGA and educational. Oh wow, she runs the educational YouTube channel also, Urogynaecology pelvic healthcare. Madam, very nice. That's an important thing. And she's also international, has many international and national publications, and also authored chapters in various books. So, Dr. Maini, the platform is yours.
Thank you, ma'am. My slides are visible?
Yeah. And of course, I forgot to tell you, your topic is hypertonic pelvic floor causes and management. This is a very unique topic, I would say. Hypertonic pelvic floor, which is a, I mean, entity which is well known and less discussed. Not well known, but not well known and less discussed. So I think it's a very, very important topic to listen
Good
to.
evening, everyone. Thank you, ICOG and Foxy, and special thanks to Dr. Kavita ma'am for making me a part of this. So, as yes, since last 2 days we are studying about the urogynecology part, and usually the discussed part is the weakness of the pelvic floor, that are hypotonic, underactive pelvic floor. But today, now I'm going to discuss about the topic hypertonic pelvic floor. What happens when the tone is raised? Is there such a concept, and why we should know, and how to manage it? So basically, pelvic floor function is in support organs, bladder bowel control, passing of urine and feces, sexual function, breathing, pregnancy, and childbirth. These all functions are done by the pelvic floor. So what happens when the tone is increased? Dyspnea, very well known to us. When the tone is increased, the patient will have dyspareunia, vulvodynia, vulvar vestibulitis, vaginismus, liver anal syndrome, anismus, pudendal nerve entrapment, scar adhesion, interstitial cystitis, endometriosis, trauma, post-traumatic stress disorder. So basically what happens in this, all the cause, whatever you're seeing for the pelvic floor dysfunction, in all of this, the tone is raised. We basically underestimate the importance of high pelvic floor tone. So whenever we treat this, any of the condition, we should take in the consideration the tone. In a chronic pelvic pain patient, 70 to 90% of the time, the tone is raised. Otherwise, vice versa, when the tone is raised, not necessarily the patient will present as pain. For an example, to better understand, the patient of vaginismus. Usually, when the patient comes, typical case of vaginismus, the patient will have only complaint of dyspareunia or not allowing to penetrate, or but otherwise her urinary bowel complaint, her all other, what just as saw the previous slide, her other pelvic floor functions normal. It's only that part, whether to activity or sexual activity, that is raised. So a high tone pelvic floor tone may present with any of this, but when there is a pain, patient complains of pain, in that case 70 to 90% the tone is raised. So now in the next time clinically application, whenever patient come of pelvic pain, you should evaluate the tone of the pelvis. So what are the causes? Traumatic injuries to pelvic area, overusing pelvic muscle, overusing majority of Kegels. Majority of when we teach the patient Kegels, they don't know, but who understand and who do the Kegel, they keep on doing day in and out. Overuse of muscles. So that is also patient should be advised. Like Kegel exercise, we usually say that 3 times in a day, 10 times to be done at each time, so 25 to 30 times. But I've seen many patients who keep on doing continuously, making their pelvic floor more strong. Chronic constipation, these are all the reason for the tight pelvic floor, that is hypertonic or overactive. So basically, pelvic floor muscle may have, there are two types of pelvic floor dysfunction, hypertonicity and the hypo one. Hyper, painful sex, hard to pee, or painful bladder or pelvic abdominal pain. Now here, when the tone is high, what happens? Females are pelvic floor voiders. We don't need to have the rise in detrusor pressure to void. Only when the pelvic floor relaxes, we go for voiding. We can easily void. Now, when the patient tone is rise, she is not able to empty the bladder properly, and she go repeated frequency, urgency she may have. And when not properly evaluated, she may be misdiagnosed as overactive, and we may give her anticholinergic. And we see many patients, I see those who don't respond on anticholinergic because the cause of overactive bladder is that raised tone. So even in that case, we should not advise the Kegel exercise. So any patient, whether you're seeing a storage symptom or the voiding symptom, you need to see the tone of the pelvic floor for the better understanding. So it affects hypertonicity, urological, gynecology, and GI, sexual, chronic pelvic pain. All of this is affected. We have seen. I'll just run fast because I think I have to show something very important to you. So pelvic floor dysfunction is the hyperactive, hypertonic, tension myalgia. Patient that pelvic floor is not relaxing. It's short. Now I'll tell you the difference. Whenever patient come to us, whenever we see majority of patient may have no pelvic floor issue, or just we are routinely doing pelvic floor examination, but many patient voluntary contract, means they have fear. So it's just momentary thing. So that is the overactive one. But when it is in a constant state of contraction, at that time we say it is high tone pelvic floor disorder. Okay. So muscle tension interferes with dynamic physiological action. Appropriate pelvic coordination is affected, contraction and relaxation. This patient does not know how to relax the pelvic floor. Just in last slide, I have mentioned anticipation of pain. Because of pain only, they involuntary or voluntary contract the muscles. So anxiety, motor control, pain sensitization, mechanical stiffness, neuromuscular activation, these are all the causes, physiology why the pelvic floor is contracted. So one more, as I mentioned, tension myalgia, muscular pain. Outside it may be relaxed, patient may be relaxed, superficial muscles may be relaxed, but the deep pelvic muscles may be contracted. So there may be a myofascial pain. So whenever you measure a pelvic floor tone, you should go deep inside, at least 3 to 4 centimeter inside the introitus hymen, and you see that area, what is the pressure by, you can see by perinometry or by digital palpation examination. So myofascial pain syndrome is something very important. I repeat, superficial perineal muscle by visualization inspection, you may find it normal. But when you palpate, you find, yes, the deeper muscles are tense. That may give rise to a pelvic floor myofascial pain. So non-function vaginismus dyssynergy I've explained. Overactivity, same with avoiding if you don't relax. Yesterday we see the wonderful session. Now evaluation, how to see. One is very important, questionnaire. Yes, questionnaire has a huge important role in urogynecology. What happens whenever patient come off SUI, urgency, prolapse, you ask some voiding questions to her. Either you ask it or you follow a questionnaire. There are many questionnaires voiding function. Just for an example, if the patient comes with SUI urgency, 5 questions to ask for urinary complaint to detect the voiding. If you just ask, do you have any voiding difficult, majority the patient won't understand. They say no difficulty. What you should ask, is she having incomplete emptying of bladder? As she comes out from the urination bathroom, is she has the complete sensation it has empty or not? Post-void dribbling. Does she strain for urination? Is there the stream is weak or poor, and does she take the prolonged voiding time? So these are the which I practice in my practice. I ask this typical 5 question particularly, and if required I go for the questionnaire. But you should ask, so in every patient of urgency SUI, minded, hyper pelvic floor tone and hypo both may coexist together. Clinical palpation is one of the best and the first investigation you do to identify. As per the evidence literature, EMG and biofeedback has been stated as the best mode of investigation evaluation to evaluate hypertonic. EMG, yesterday in Dr. Aparna ma'am's lecture, we saw how it is. So when we routinely do uroflowmetry, we usually do it with EMG and PVR. So with again, when there is high PVR, yes, the patient may have problem. But if post-void residual volume is normal, then it doesn't mean that patient may don't have any voiding issue. Vaginal dynamometry, it's practical, no, not clinically very good done. Vaginal census, perinometry, transperineal ultrasound also you do by that. Digital perinometry, MRI, dynamic MRI. These are some studies. I think I have some less time, so I'll rush. So how you examine pelvic floor tone practically at rest, you see it. You do ask her to do Valsalva. Valsalva and straining are two different techniques. They are not the same. There are many literature on this. Then you ask to do the contraction, and then again you ask her to relax. That is Valsalva. You don't ask her to strain. Inspection, this is the way you see the deep. From clockwise you can go, or anti-clockwise rotation, levator, ana, obturator. The position, the muscles where you feel it, it is shown in the diagram. So you inspect it. Inspection, many times you may find it normal, as I already explained. External palpation sensation, internal deep palpation, you see the muscle, and obviously do the corrector. So you may find pelvic trigger points, band sensation, you see any injury, old scar marks, tenderness, muscle tone, coordination. You ask her to do the 4 steps which I showed in the last slide. Sensation, anal wink reflex, and anal sphincter tone also. Many patients of chronic constipation, they have pelvic floor dyssynergia. There are various again types. So there is one of the manifestation of hypertone pelvic floor. So as I said, digital assessment should be approximately 4 centimeter inside the vagina, and only the index finger should be used in case of very narrow hiatus. And when you suspect the patient of vaginismus, high tone, don't do PS examination. Give very gentle, right from vulval mapping with cotton swab, and then go deep inside. And then puborectalis should be palpated. So you should see the resting tone, quick contraction, ability to relax. Then it is there is a difference between muscle tone and muscle function. We are talking about muscle function, which has one of the component of tone, voluntary contraction. What is the strength? What is the endurance? The repeatability, patient is how long she is able, co-contraction, other muscles are contracting, and relaxation. So this is one of the chart, perfect like Oxford grading we have this also. In this we see the same resting tone and contraction, what I have said just now. I'm just moving, I'm seeing the time. I want to show you this, sorry. So this is the modified Oxford, which we all do it. I think we know this. This is the perinometry, where we can 3 to 4 centimeter inside, and you see the how much it is raised. And external visual observation, what happens during contraction, it is usually the initial step, but only observation is not there, as the inward movement of the skin may be created by contraction of the superficial perineal muscles, and there may be no contraction of deeper elevator ani muscle. Now, how you manage? First line investigation is pelvic floor physical therapy. You can refer to a pelvic floor physiotherapist. EMG biofeedback is the gold standard or best thing to do. Transperineal ultrasound, you can teach her how to do it. You can show her, just as a way of one of the form of biofeedback, which where one more function of transperineal USG. Oral medications like diazepam, baclofen, muscle relaxant basically are given. Same medications are given intravaginally, but unfortunately in India we don't have intravaginal preparations of the same. Botox, local anesthetics in case of myofascial band trigger points. Transcutaneous nerve stimulation, percutaneous nerve stimulation is also very good modality. Sacral neuromodulation, yes, yesterday only we have seen in sphincter dyssynergia, when there is dysfunctional body, this has a wonderful role. Surface EMG I have explained. This is the biofeedback which we do it. Transperineal, you can see the AP diameter, how much it is. Then you ask the patient to relax, you ask to contract, and you see how much it has reduced or not. Transabdominal, again with by abdominal also, you can see whether the patient is squeezing or lifting. These are all the various methods where you can evaluate. At the same time, you can give her the visual biofeedback. These are all the various techniques, whichever you are having available, you should do it. So dynamic MRI is one thing. This I'll share the slide. This is how you should go. This is basically a chart where you should how you should proceed for the high tone pelvic flow. So tips, anti-gravity position, avoid prolonged standing, sitting, apply heat to relax pelvic floor, relieve pain, pelvic floor. Just 1 minute, I'll take pelvic floor relaxation with deep breathing exercises, yoga, music, vaginal dilator, especially in case of trigger points, myofascial band, vaginismus, and that management is required. Stress management, cognitive behavioral therapy, proper bowel emptying habits, plenty of fluid, fiber, avoid straining. Hovering position, many of them don't relax completely on the toilet seat if they are using public. So if you do hovering in long term, you may have developed hypertonic pelvic floor. Correct sitting posture, maintaining curve in lower back. So as the ma'am initially started, is there is a delay in diagnosis, no doubt about it. And let's not pretend that things will change. We keep doing the same things. Hyper and hypo may exist together. Any case patient with hypotonic symptoms, you should check for the hypertonic of pelvic floor also. And this is my YouTube channel, and I take the opportunity to invite you to all for the SOPSI National Conference next year to be held in Delhi, where you can detail go with this vaginal surgeries. Thank you. Thank you so much.
Thank you, Dr. Moini. It was a very lucid talk. You explained very beautifully. And the very interesting thing which I just learned, that hypo and hyper both can exist together.
Coexist
Also.
together, yes, ma'am. And in that case, we treat first hyper and then hypo.
Yeah, so that is a little, normally we think na, either it is a hypotonic
No,
condition
no,
or
it
it
may
will be
really be.
hypertonic. So both of them are they can coexist. The new thing, obviously, and to evaluate it also,
Thank you,
because
ma'am.
always we keep on thinking about hypotonic pelvic floor. Hyper rarely one thinks into. So the very nice and informative talk. Thank you very much.
Thank you.
And we are definitely coming to AI Suji, don't worry.
Thank you.
So organizers, I'm sure the third Dr. Fessy must have joined. Hello.
Yes, ma'am, she has joined.
So Dr. Fessy will introduce Dr. Kejala.
Tracy sir is not available.
He's not available.
No.
Yeah, you can introduce, madam.
Okay, I'll introduce.
Said
My
he is
pleasure.
joining. He did join.
So the next speaker is Dr. Kejala Bhutia. She's senior consultant obstetrician and gynecologist, and subspecialist is urogynecologist. She's in the department of KK Women's and Children Hospital at and her address is of course Singapore. Why? Of course, very good. She's at one. She's assistant professor Duke and US Graduate Medical School Singapore, and she's chief KKH Singh Health Duke and US Pelvic Floor Disorder Center, clinical lecturer and FIGO Urogynecology Associate
so
member, IUGA
thank
Global
you.
Health.
Thank you. I think it's all right.
Yeah, Dr.
Yeah.
Keza. Thank
So,
you very much.
yeah. Good evening, everyone, and thank you for all staying back
Yeah,
so
and it is
late for
very
the
nice
final
of
talk
you
of
to
this
take a seat.
wonderful course. Yeah,
Thank
it's
you.
9:30 here.
Okay,
So
but
I'm still awake. So let me share.
Yeah, please.
Let me share my slide. I think, yeah. Yeah, you can see the slide, visible?
Not yet.
Not yet. Just
it's yeah.
Probably
Now
it's a
we
lag.
can see it. Yes.
Now move your slides.
Yeah. So it is my pleasure to speak today on the role of venotes, and it's a vaginal natural orifice transluminal endoscopy surgery in urogynecology. So minimal invasive surgery has undergone a remarkable evolution over the past few decades. We started with abdominal and vaginal approach, then came a laparoscopy, then later is a robotic surgery, so which has improved our visualization, precision for the surgery, and better hemostasis. Now, the V-nodes represent the next step in this journey. So, why V-nodes? So, it combines the best of both worlds. It has a vaginal route with least invasive natural access, and at the same time, it has a laparoscopic approach advantage, providing a superior visualization and better hemostatic control. So, so everyone keeps saying, why you have transitioned to V-nodes now? Yeah, almost my now benign, especially the benign gynae, almost 90% are done by V-nodes, and all my laparoscopy and robots are almost like rest in peace. So traditional vaginal surgery can sometimes be limited, particularly when trying to access to adnexa, or you faced with those non-prolapsed or enlarged uterus. So V-nodes typically overcomes these challenges by allowing the access to the adnexa that could be potentially inaccessible in traditional vaginal approach, and as well as allows the removal of the enlarged uterus and non-prolapsed uterus. And most importantly, it allows the direct visualization of the entire upper abdominal cavity. Now let's consider the benefits. It has a cosmetic advantage, having a scarless surgery. It has improved ergonomics so that surgeon can have a clearer view for entire pelvic structure. Time efficiency because of the shorter operating time, faster recovery, and of course team efficiency as well, as the procedure doesn't need skilled assistant, and we can typically do with a fewer surgical assistant. There's a physiological advantages with the V-notes can be performed in lower pneumoperitoneum pressure, less than 10. So this can be relevant and very advantageous in high-risk patients like high BMI or those with previous any abdominal plastic surgery with barrel abdomen where ventilation can be challenging. Of course, technical ease, where target tissue is closer to the port, less restrictive movements, and classing of instruments. So what are the other type of procedure which can be performed, like urogyne procedures, which can be performed beyond hysterectomy, is V-nodes adnexial surgery, high uterosacral ligament suspension, sacrocolpopexy, sacrospinous ligament suspension, and lateral suspension. So Lee and group has published data reporting around 11% of the adnexial surgery and 5% of sacrocolpopexy. Similarly, meanwhile, the systemic review recently in 2024 highlights that most of the urogyne V-nodes procedure done was uterosacral ligament suspension, followed by sacrocolpopexy and sacrospinous ligament suspension. So, of course, this reflects a growing trend. V-nodes is being adopted not only for the adnexial surgery, but increasingly for more complex prolapse procedure in. So let me share our institutional data, which I think can reflect both opportunities as well as challenges in V-nodes adoption. So as you can see in our center, as compared to more than 250 SSF surgery annually, we do perform around 40 cases of average vaginal high uterosacral ligament suspension and around 40 cases of vaginal adnexial surgery. In comparison, we do around each year 20 cases of average V-nodes adnexial surgery and very small number of V-nodes USL of around 4 cases. So again, as you look at the indication, most common V-nodes procedure in our center is hysterectomy. These are often for the patients with large uterus, presenting with urinary pressure symptoms, or at times with avoiding dysfunction, or endometrial hyperplasia or ovarian tumor, reflecting the typical advanced age of older population which presents in urogyne setting. So I would like to, of course, here, so what is encouraging is that we introduced the V-nodes in 2021, but our experience is growing strength by strength every year. But our limitation we face with the V-node high uterosacral ligament suspension is because of the cost, where cost is a concern. Cost concern is quite significant due to the device, and as our center is a public center, so not all patients will have insurance cover, and moreover, this procedure can still be performed effectively via a conventional vaginal route. So here I'm going to like to share the demonstration of the oophorectomy in 72-year-old lady with a pelvic organ prolapse as well as background history of breast cancer. As you can see, laparoscopy view from the vaginal port, the pelvic cavity is visualized very clearly, excellent visualization, minimal invasiveness. We proceed with identifying the IP ligament using the sealing device, sealed and is divided. As you can see, I have put a gauze here. So to protect the basically accidental, of course, contact of the sealing device and of our lateral thermal spread to the bowel. So on the left side, adhesion was encountered, most likely related to previous tubal ligation. These were carefully dissected and procedure was carried out in stepwise manner. So first addressing the ovary and followed by tubal ligation. So this sequence of course, steps has provided better access and improve visualization. So, next on to, I would like to share the video on the video demonstration of high to uterosacral ligament suspension via V nodes. So first, we carefully visualize the ureter, and using a gentle and medial traction, we create our best exposure possible and delineate the uterosacral ligament, and while keeping the ureter safe. And once the site for the suture placement is identified at the level of the ischial spine, we introduce the two sutures serially into the proximal portion of the ureter. Very important to take the stitches while ensuring the ureter and other vessel structures, including the bowel, remain protected. So as you can see, the vision is really clear as compared to vagina, where typically we relies on palpation finding. So here I'm using a PDS delayed observable suture. I try to avoid permanent suture, including proline or ethibond. So we repeat the similar step on the other side, contralateral side, to achieve a symmetrical suspension. As you can see, I am taking the bite from medial to lateral. It's best to take from the lateral to medial, but it's my own personal preference, because I feel more comfortable with the ureter because it's away from my surgical field, but I'm more worried about my bowel, so I try to avoid coming from lateral to medial. But ideally, it should be coming from lateral to medial instead of going from medial to lateral. So once the suspension, after the end of the surgery, once the bilateral suture suspension has been done, do not forget to do perform the cystoscopy to check the ureter's patency. Even the risk of having a ureter kinking via V node is less than 1% as compared to 11% in the vaginal high uterosacral ligament suspension, but it is always good to do the cystoscopy at the end of the procedure. So what evidence we have internationally. So based on this, a recent systemic review published in 2025 has shown overall conversion rate was very low for a V node adnexal surgery of around 1.37%, and most of the time is because of unexpected adhesion. And as far as for uterosacral ligament suspension, the study again done in this year by Wang Qi 2025, as you can see, all this urogyne procedure is a very novel, it's a newly emerging, so that's why all our data is very recent in the last 3 years. So excellent success rate, only one failure, that also not for the apical, it's more for the anterior prolapse recurrence, and there was a 2% of intraoperative complication, including conversion to vaginal uterosacral ligament suspension because of the adhesion, 3 bladder injury, and 1 ureteral kinking. Excellent significant improvement in patient-reported outcome measures as well as satisfaction rate. Similarly, another study, 2024, excellent 24 to 100% success rate with a complication of 2.2 with the uterine kinking of 1 and 2 cystotomy. Now, as far as sacrocolpopexy is concerned, most of the available evidence has come from China with relatively smaller studies, participants number. So I continue to perform a laparoscopy sacrocolpopexy, but I have a concerns using a vaginal mesh via vaginal route, similar to the issue seen with the vaginal mesh. So clearly, we need more robust evidence to support its widespread use. So as far as, again, V node sacrospinous fixation is concerned, again, most of the data has come from China. So V nodes may offer advantages here by providing a better visualization and more precise placement of SSF sutures. So this is my last slide. The V-node represent an exciting advance in minimal invasive urogyne surgery. It offers a significant benefits, but current data is very limited. But preliminary data suggests excellent anatomical and functional improvement covering all domain, bladder, bowel, sexual function. But most important is patient and use of standardized outcome measures is important. Limitations remains, including the learning curve and need for long-term robust data. So this is my last slide. Thank you for your kind attention.
Thank you, Dr. Khajila. It was really very excellent presentation and new insight on a new topic. First time I think I'm seeing this surgery because you've covered all sacrospinous fixation to high uterosacral ligament fixation to self-injectomy to everything you have done. So it's beautifully presented. Thank you very much for being with us here. And I almost visit every month to Singapore. My daughter is there, so I'll try to meet you.
Oh, you must, I must. I'm in the heart of the city, so
it's just on
easy to
Bukit
find
Road.
me.
You are there. Yeah, I'll take your number from the organizers.
Sure.
So Mukta, you can.
Yeah. Thank you, Chairperson and speakers. With this, we come to an end of all our sessions and we will move forward for the post-test.
Yes.
So, post-test is shared in the Google link. So, ma'am, we will have 15 minutes for post-test.
Yes, ma'am. Link has been posted in the chat box, ma'am.
Yeah. So we have the link posted in the chat box and everyone to just open the link, just look at the question and give your answers. And ma'am, 7:30, is it okay?
Yes, 7:30.
For after 7:30, we will wind up and we'll look
Ma'am,
at the
timer
correct
is
answer.
there, huh?
Timer
For
is
15
Yes,
minutes.
ma'am.
And can you give a warning bell at just
Yes,
one?
ma'am. 1 minute left. I will give.
Yeah, someone has posted that a warning should be given 1 minute.
Yeah. Yes, last day also we did that.
Yes, ma'am. So
I think we can take leave as a chairpersons. The
किरण
is
मैडम
it
रुक जाइए ना
yeah,
थोड़ा सा रुक
sure.
जाइए
Thank you.
थोड़ा रुक जाइए if you're
Chairperson,
not busy.
thank you so much for your kind presence.
Yeah.
Okay, I'm there.
Yeah. अभी थोड़ा हम लोग वोटर थैंक्स कर देते चले जाइए
There is only 2 minutes left. There is only 1 minute left. Suman ma'am,
Yeah,
please.
we need the answers now. Mukta, you read out the right answers. Okay.
Yeah. So why V nodes consider advantageous in prolapse surgery? Because it provides direct access and precise suturing of uterosacral ligament, which specific anatomic factor during V node cystectomy potentially simplifies the dissection. So it's direct visualization, allowing for improved identification and controlled of vessels. Ideal time for cervical cerclage is
Option
end of
C.
first trimester.
Still, answer is C. Okay. Then move to this.
NTNB scan. And best explanation for obstetric fistula because of lack of emergency care. B. Ischemic necrosis leading to VVF because answer is C. Bladder, neck, and urethral region. Major surgical procedures in female still is cesarean section. Answer is C. Incidence of hysterectomy in India. Answer is A. 12 to 13 per thousand. Advantages of lap cerclage is answer is B because it's around the isthmus, so better cervical length. Advantage of retropubic sling, answer is C, more effective in intrinsic sphincter deficiency. In recurrent UCI, most important diagnostic tool is leak point pressure measurement, that is C. Percentage of urogenital fistula in obstetric causes in developing countries, answer is B, 95%. Urogenital fistula due to gynecological surgery in developing country more common, 83%, hence answer is B. 45-year-old after TOH leaking as well as voiding uretrovaginal fistula, answer is C. Most common site of ureteric injury during hysterectomy is the junction of uterine artery, answer is B. Most effective prevention of thermal injury, answer is B, that is applying injury only after clear visualization. Poor prognostic factor for fistula surgery is HIV positive status.
Hypertonic pelvic floor may cause. Answer is D, all of the above. 18. Hypertonic pelvic floor leads to. Answer is D, all of the above. Question number 19. Which intrapartum intervention has been shown to be effective in reducing the risk of the 3rd and 4th degree tears during vaginal birth? Answer is B, that is warm compression during 2nd stage of labor. Question number 20. For a nullipara undergoing instrumental vaginal delivery, which approach is recommended to help prevent OC? Answer is C, that is perform mediolateral episiotomy at 60 degree. So we complete with the correct answers. And so Mukta, are you there? So with this, we come to the end of our 3-day ISOG certificate course on urogynecology and pelvic floor repair. And for this, I'm really thankful to the ICOG team led by ICOG chairperson, Dr. Parag Biniwale, then Sheila Mane madam, who is ICOG chairperson elect, then ICOG secretary, Dr. And also to our FOXY president, Dr. Sunita Tendulkar madam, and Secretary General FOXY, Dr. Suvarna Khadilkar madam, and also to all the esteemed chairpersons who were there till the end with us. So we can see the entire doctors who have been selected for today's program, all of are there, and also the faculties who have done so much hard work to present the best to us. And I think it is a very good visual treat to all the newcomers who is attending as a participants and taking part in the question and answer session. And I was so happy to see that almost all of them have answered and they are telling that we have passed. So the credit goes to our speakers and also chairpersons for encouraging them. So thank you very much for being with us here. And we'd like to see you more often in the next ICOG, this type of certificate courses. So thank you once again very much. And thank you, Dr. Kavita Bandmal, for joining us again. And all the coordinators right from the beginning, Dr. Meena Mahalingam, then Dr. Sandeep, and today Dr. Mukta Agarwal. They have done wonderful work, and we are so relaxed to give them, hand over these charges to them. And in the last, but not the least, I cannot forget to mention our this technical team, especially led by Nilima and Shreya. They have wonderful job. And they were right with us, whatever we asked, even in the test messages, whatever we wrote, and within second, the answer used to come. So we are so relaxed. Thank you very much, and wish to join you once more if we get a chance this year. I think our turn is over. So Thank you so much. Thank you, everyone, including President Foxy,
Thank you.
Secretary, ICG Chairperson, Secretary General Mukta, Meena, and Sandeep, and Suman Madam, Devi Sharma Sir, Kiran Pandey Madam, to whom I can see all the chairpersons, all the speakers for making this CME so successful. Thank you so much.
All the
Yesterday the
participants.
registration was 894. Yesterday the registration was 894. So it was so good to see.
Just for the participants, they will, if they have completed all the 3 days course, taken the post test all the 3 days, and if they have secured more than 50% marks, they will get a ICOG certificate.
10 ICOG credit points.
Yeah, 10 ICOG credit.
Thank you so much. Thank you, Mukta, for joining us, for staying. Actually, I had some emergencies. That's why I had to run. Okay.
Somehow Wi-Fi. ठीक है, Mukta. It was very nice. We could do it.
I knew na. That's why I kept her. So thank you so much. Thank you, Mukta. And Mukta is my relative also, Suman Madam. You know.
I was not knowing.
Okay, her in-laws house is